Schedule. My name is Ambrish Sahai. I am Senior General Manager, Sales and Marketing for Pharma Care Division of Sun Pharma. Sun Pharma, as you know, is the #1 company of India and globally 4th largest. And we are #1 in 10 therapeutic segments, including cardiovascular, diabetology, neurology, urology, nephrology, oncology, derma, and gynecology. ENT is our frontline forte, and practically in all the major events of ENT, whether ISOCON, Rhinocon, AOCON, we participate, and we do a lot of live surgical workshops, and we participate in many state conferences as well. Today is a very special evening because we will invest our time in a surgical workshop by none else but by a legend of ENT, Professor Janakiraman. I think any introduction for Professor Janakiraman will be short of words. So without further ado, I would not like to delay the function further. I would like to invite Dr. Archana on the dais to give a brief introduction of the today's event and of course of the
Thank you all of you and welcome from Sun Pharma again. Sorry, PPT.
Pack the nose. Please pack the nose.
So I request first Dr. Anthony on the dais, and I request our cluster head, Mr. Nitish Srivastava, to felicitate him. Dr. Anthony, he himself is an expert, teacher, surgeon. More than 25 years of ENT surgical experience and plus training, UG, PG, and N number of medicals. He is an examiner, mentor, PG degree and diploma for ENT courses, demonstrations from regional to international courses. More than 4,000 FESS, over 3,000 endoscopic surgeries, and N number of difficult surgeries to his kitty. And he has expertise in laryngectomies, then pharyngolaryngotomies, total maxillectomy, and N number of radical neck dissection. So we welcome Sir here, and Sir will be our moderator for the session today. And I have honor today to introduce Dr. Tiruchinarayan Janakiraman Sir. He has done his education from MMC Chennai, internationally renowned surgeon, academician, expert pioneer of skull-based surgeries and various ENT neuro and tumor surgeries. He is a multi-talented personality involved in numerous health welfare and international. He is an international faculty to various countries and various universities. He's a quiz master, he's an artist, he's a singer, he's a ranker throughout his education, researcher, author to many chapters, books, and he has a number of publications to his kitties. And along with, he has an important role as an international pioneer in endoscopic management of tumors, ENT and skull-based surgeries worldwide. He has multiple awards and honors in his field, as with special mention of Stamberger Award for Excellence in Teaching 2022, which is the recent award. If I'll start taking his awards and felicitations, I think 2-3 hours will be less for that. Along with enormous work, he has pioneering work, research work on new concepts, classification techniques in endoscopic sinus and skull-based surgeries, thousands of free medical camp, enormous training workshop, faculty sessions, clinical surgeries, and the way he is training n number of thousands of doctors across the world. I am surprised how much time he gets for his day-to-day life, because I don't think 24 hours are adequate for this work. So with this, I welcome both the expert doctors to today's workshop, and welcome all of you for this interesting workshop for today. Are we starting the workshop right now? along with Dr. Janakiraman, Dr. Shilpi, Dr. Harshtika, Dr. Avinash, Dr. Lakshmi Shreya, and n number of team members are behind this workshop who will be handling the live surgery here for all of us for next 3-4 hours.
So can we start?
Yes, please.
Okay, first of all, a very good evening to all of you. Thank you for your very nice words, madam. It's always a pleasure to teach. And I always say that I would be recognized more as a teacher than as a doctor.
True, sir.
So by teaching, we actually propagate knowledge. And by that, we treat millions of patients across the globe. So I first of all thank Sun Pharma for this very, very elaborate arrangements. Some people are sitting in Goa, some people in Hyderabad, some people in various parts of the country, and also various parts of the world are watching it. So Sun Pharma is dedicated to teaching academics, and I really appreciate their endeavors to make it so academic. Thank you, Sun. I want to also thank the my beloved assistants, Shilpi Bhatia Sharma, who is actually the backbone, and I will call her the brain and the spinal cord of my surgeries. And I also thank the management of Gaman Hospital, who have been kind enough to provide this beautiful platform for me to demonstrate. And Dr. Sri Harsha, who is the consultant, he is my very favorite student. And I really thank Dr. Sri Harsha. And of course, I have my team members, Dr. Avinash from Hyderabad, and also Dr. Rupa. And yeah, we have several other people. Now, I thank the anesthetist team for this wonderful anesthesia. Dr. Mahati is always very close to my heart. She gives beautiful anesthesia in all our cases. Now, coming to the moderator, Professor Anthony, I call him the encyclopedia of VNT. Whenever I have a doubt, immediately I phone up to him and ask him over the phone. And we're very close friends right from my MBBS days. Both MBBS, DLO, MS, all we did together. And really love him, actually, loads. Now, coming to the cases lined up for today, without much ado, we will straight away go on to the cases. The first case is a very, very interesting case. A 45-year-old female presents with history of right nasal discharge on bending forwards. So the discharge actually is positional, watery, and very often she gets a lot of watery nasal discharge. So whenever a patient comes with unilateral nasal discharge, positional on bending forwards or when tilting the head, we should always think of CSF rhinorrhea. So as you know, CSF is produced by the choroid plexus, mostly in the lateral ventricle, and it circulates around the ventricles, so the foramen of Monro, third ventricle, aqueduct of Sylvius, the fourth ventricle, and then two foramens into the spinal cord. And this CSF actually has got some immunological functions as well as buffering the brain. Now, CSF rhinorrhea is completely a skull-based surgeon's forte, means an ENT skull-based surgeon's forte. No longer transcranially done in most indications. 98% of the indications. Now, let us make it very, like a discussion, not like a class, because you're all in Goa. I know how your mind state will be in Goa dancing. So we'll do the same. Professor Anthony, please make it very, two-way communication. Now, this patient actually has been sent to us by some good friends of us. I really thank, and we're doing it free of cost. Both the cases we are doing free of cost. And thank you very much, Sun Pharma, for sponsoring these two cases. Now, let us go on to the CT scans. You can see here. Can you come nearer? So this patient actually presented with a right nasal discharge. So the first thing you have to ask when the patient has a nasal discharge is, do you have headache? The first question I ask is headache. Number two, I ask is blurring of vision. Number 3, I ask is double vision. Number 4th, I ask is tinnitus. And these are the 4 important features of benign intracranial hypertension. So have they had history of trauma or not? So these are all the things we should always ask when you have a case of CSF rhinorrhea. Now, this patient didn't have any of these, just had nasal discharge. So the first step is to collect that fluid and send it for biochemical analysis and look for glucose and also beta-2 transferrin. So glucose, anything above 40 or 50 is indicative of CSF. And this patient had a high glucose, low protein, and so definitely this is a case of a CSF rhinorrhea. Patient has not had history of meningitis. It's very, very important to ask for history of meningitis. And also you should always think about space occupying lesions. So you should always think why the CSF rhinorrhea has come. Is it because of a tumor in the brain? So you always need an MRI. Always need an MRI for CSF rhinorrhea. Whether you take a CT sinogram or not, the investigation should include, the spectrum should include an MRI to rule out any space occupying lesion. This is very, 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 very important. Now, let us see what this CT scan. First, I took a CT scan, intrathecal contrast, and also MRI for this patient, and see what it says actually. You can see that the frontal sinuses. So if you have CSF rhinorrhea, there are 2 things you can see in a CT. Number 1, you can see the contrast coming down. Of course, this is not a CT with contrast. Intrathecal contrast, metasemate CT cystinogram is the gold standard investigation for CSF rhinorrhea. This is a plain CT done elsewhere. So, but you have to look for any polypoidal changes in the region of, in the vicinity of the pseudomeningocele or encephalocele. So let us see this. You can see here, that's the frontal sinuses. Always look for the septum. Always look for the septum in a CT. Why do you look for the septum? Because you might need nasoseptal flap for reconstruction. So I always look for the septum first. So you can see the septum is slightly deviated towards the right side. You can see that very clearly. And of course, it's not been operated before. You can see a concha bullosa here. And look for the cribriform plate. The commonest site of CSF leak is the cribriform plate. This is very important. Look and basically try to avoid arrow marks in a CT scan or an MRI. In fact, they are sometimes misleading. The radiologist put on arrow and says this is the one, but sometimes it can be it may wrong. So don't read a radiologist's opinion for every CT or MRI. You should be able to read the MRI or the CT. So here they have marked it as the cribriform plate. Okay, fine. It's okay. Then we will go here. The ethmoids look normal, the posterior ethmoids. And I started little polypoidal tissue here. And when you look at it here, the sphenoethmoidal recess, you can find something like sort of a soft tissue opacification. And when you look at this, there's a lateral recess. You can see here, that's a lateral recess. And that's actually the V2, and that's the median nerve. That's called the VR line. This is the VR line. So you can see medial to it and above, you can see a small bony dehiscence here. Can you all appreciate it? Professor Anthony, are you there with me? Are you hearing me?
Yes, sir, we can hear you.
Why is Professor Anthony not talking? Mic is not
I think his mic is not working, sir. Just give us a moment.
Okay. Shall I wait or shall I continue? I'll continue.
Hello.
So you can see that. Hi, Anto.
Yeah, Janakiraman.
Yeah.
This looks like a Steinberg canal leak.
Yeah, it looks like that, but I'll tell you there's a small googly in it. That's a little dehiscence here. You can see that very clearly. That's the V2. And you can see that's a very deep Steinberg canal. And then this is definitely filled. But what is surprising is this patient, the opposite side sphenoid also is filled. If you look at it, the opposite side sphenoid is also filled here. So I'm not very sure about whether it's a Steinberg canal, but definitely there's a dehiscence here. That is for sure. Now, looking at the MRI, if you look at it very carefully, get me the MRI, always look for the T2. So you have to look for features of BIH. So you have what is called the modified Dandy's criteria. So what are the things you have to look for? You have to look for the tortuosity of the optic nerve, and you look for the perioptic space widening, and then you look for slit-like ventricles, you look for enlargement of the Meckel's cave, look for empty sella. So all these you have to look for. So none of that was present in the MRI, but what you can see here, the radiologists have marked the cribriform plate. Even though CT scan was more towards the Stenberg canal, the radiologists have pointed out saying that this could be a cribriform leak, and looks like sort of a cribriform leak here. There's a small, so basically MRI cystino. So what is MRI cystino? You have two kinds. Number one is heavily T2 weighted MRIs can also be called MRI cystinos, or we can give a dye, gadolinium, and take the MRI. Basically, we avoid gadolinium. The reason it stays in the brain and there are complications. That's why in our center, we generally avoid, unless it's really critical, we directly go in for intrathecal fluorescein. So it stays for around 24 hours. You have to repeat MRIs. You know the cost of an MRI, right? So basically what we do is, you see there is a little suspicion in the cribriform area, but here also this looks as if there is a continuity between this brain and this area in the Stenberg canal. So it could be either a multiple leak, it could be a Stenberg canal leak, or it could be a cribriform leak. So that is the diagnostic dilemma in this case. So how do we proceed? So number one, you confirm whether it's CSF. Yes, it's confirmed. Number two, site of the leak. Site of the leak is very important. Here we have a little confusion whether just a cribriform or a cribriform with a Stenberg canal. So the best would be for me an intrathecal fluorescein. So intrathecal fluorescein will catch whether both the sites are leaking or it's only one site. Or what you can do is expose both the sites. Expose both the sites and see if the leak is coming from both the sides. That's exactly what we're going to do in this case. And if you have any doubts, you can ask me. Anto, shall I start?
Yeah, please.
Yeah, you can have a discussion. Anto, rumba silent. I mean, like, you know, very abnormal of Anto to be like this. Let's see. Okay. I'm going to wash up. Evoke a discussion, Anto.
Yes. Any questions?
Any questions you can ask?
Good evening, sir. Sir, your thoughts about CT cystogram and MR cystogram, sir? The need of CT cystogram in every cases.
See, this entirely depends upon the availability, financial status of the patient, as well as the surgeon's point of view. The main thing is that gold standard is the MR cystogram. Dye-injected MRI is the gold standard. But CT cystogram is taken as the minimum requirement. You inject the dye and look for the site, unless it is very obvious. Few cases, when you put an endoscope itself, you will see that meningocele or with a plain CT, you can see the defect very well. Where large defects more than 1.5 centimeters, you can usually see. And if that is the case, it's fine. The problem comes when the discharge is very less and you have not established whether it's a CSF or not confidently. If you not got that result of CSF, then if you take a CT scan and if your windows are not correct, if you take a bone window, it's okay. If you don't take a proper bone window, if you take a brain window or a soft tissue window, you get a window escape. That is the normal bone itself. It appears different in the various places. So if that is the case, we can see so many places may look like a defect, but actually it may not be the defect. So if you have if you are, first thing is you should diagnose the CSF. And second thing is if you identify that area of leak, like what Janakiraman said, there may be multiple leaks will be in the same patient also. So it's always safer to do a CT cystogram or
Elevator.
highly weighted T2 images. Highly weighted T2 images, you see the fluid as the white white in color. So if there's a CSF leak, an active leak, you can see that exact area and you can identify that area. Other things are all not used very commonly nowadays, like fluorescent injecting inside that. They're all not used very commonly because of the advent of the CT and MRI. You can easily get the leak area.
Okay, I'm starting, Anto.
Yes.
So the first protocol in CT, CSF leak is I will examine the nasopharynx. So the first thing I would like to do is to examine the nasopharynx because all that CSF should flow through the nasopharynx only. And the second important thing is we should not miss a paradoxical CSF rhinorrhea. So you see whether ask them to give a Valsalva, Madam Valsalva. Always look for the eustachian tube orifice. That should be the first. I have seen cases which have been operated elsewhere. What happened was they missed a CSF, paradoxical CSF rhinorrhea. Okay, now you can see here that actively CSF is not coming out. So this is the first step. Examine the eustachian tube orifice. Okay, now the second step is examination of the cribriform plate. So how do you examine the cribriform plate when the septum is deviated? I don't know who packed it. I'm sorry, there's a little trauma. Now, the first step is to go up and then gently push the middle turbinate. Gently push the middle turbinate. Now, you have to manipulate your endoscope in such a way that you are able to see the cribriform plate. Now you can see very well that's the superior turbinate. That's because of the trauma created. The problem is the people residents who pack, they fail to understand that if you produce trauma, yesterday also one resident packed and he produced trauma. So they fail to understand that trauma should not be produced in CSF rhinorrhea. Give me a coblation.
Irrigation.
Now I'm looking at the cribriform plate and I can't see any leak. Wait. Blue. Okay, I'm now going to coblate that area. But the problem again is if you have to coblate, then you will lose the Haddad flap. So you see how many problems you have just with a small step. A resident can screw your happiness. And he will take it lightly and say, sir, you do it. But the problem is we are not able to do a Haddad flap now. Now, let us see again. I don't want to use the coblation because it looks like a Stenberg canal to me. Okay, now I'm going inside. I'm examining. This is where the radiologist has told there could be a leak.
Irrigation.
I'm going inside. Yes, irrigation. Yeah, irrigate.
Janakiraman, if it is if you confidently think it's a Steinberg canal leak, you can coblate, no?
No, then I need a Haddad, right?
Unless if you don't do a transgenic like that.
No, now I'm going to show you a new technique. That's why I knew you'll ask this question. I wanted this question from you. See, now what we have started doing is an ipsilateral Haddad for a Stenberg canal leak with a transpterygoid approach. We're going to see that. So we evolve every time, right? So we don't want to follow everybody the same contralateral Hadad. That was the teaching. But now in our center, we have already done 3 cases of Stenberg canal with an ipsilateral Hadad doing a transpterygoid approach. I'm going to show you that. That's the idea of this presentation actually. So now I'm very confident that it's going to be a Stenberg canal leak by backbiter.
Ready. Debrider ready.
So I'm just going in for a high unsonotomy. That's the unsonet here. A high unsonotomy.
Which backbiter is that?
This is Nagashima, but actually it's not my instruments, my set of instruments. So this is my sweet resident Harsha's.
Harsha, where did you got it from? Where did Harsha got it from?
I think Santosh Surgicals. Most of my instruments are Santosh. Sorry if I'm propagating a company, but I love those instruments. And they are now international. I can see them in America. I can see them in wherever I go. I see them now. Okay. Now it's like Jesco, you remember?
Yes,
Anto?
that's what I'm wondering. After that Jesco, you don't get a good backbiters.
Yeah, Jesco one time was on top. Now
They don't
Santosh is going all over the world. American Congress also I saw him last time. Of course, pre-corona. So here you see there's a septal deviation. So I'm keeping my scope around 1.5 centimeter away from this. So this is the idea. This is very important. If you have this kind of a septal deviation, so see that I'm now trying to. So the most important thing is to define the skull base in a case of CSF leak. So that's the posterior ethmoids. So see the movements. Of course, I'll be showing the next case, which is an AFRS. Irrigate, please. Irrigate. So in AFRS, I'll show you.
You named this technique as something
No, not now. I'll tell you the Jula technique. Not yet come there. I'm just doing the posterior ethmoids. When I go to the sphenoid, I'll tell you what the baby walk. All that I'll do in the next case. Now I just want to identify the leak and get a new technique. This has been, when I did it first, I did it in the Mucar case 2 years back. And I was jumping because I did it. And then I thought maybe I was the first in the world to do it. And then I went through literature. Shilpi found that, it has already been published by Carl Schneiderman. So one case has already been done. So I was a little depressed, but I did with my own idea. I'm going to show you that technique today.
Like Cal will look, 2 people can do the same thing across the.
Yeah, exactly. But he has already published it, so I can't publish it anymore. Anyway, it's okay. But I was happy that I thought about it. Okay, now this is called the gauze piece dissection. This has been published by us, and this publication is done in Russia by Dapsinia. So with the gauze piece, we dissect the posterior ethmoid. It's very atraumatic. So you can see now there's a very little space. I'm just working on that little space. Even though there's a septal deviation, I don't want to do anything to the septum because of the nasoseptal flap. Now you see here, I'm trying to push it, go inside, and then
On the foot.
see that's the sphenoid sinus now. Okay, now having done that, irrigate, my dear friend. Okay, now let us go inside. Give me the debrider. Now I'm just going to go for the posterior ethmoids. Push the middle turbinate, go inside.
Left foot.
Ma, block nanikiramma. This is a block. I gave you as a block and you're giving me the same again. Now, the most important thing in CSF leak is that you don't bother to use the debrider. Generally, when I'm doing without demonstration, I don't use the debrider. I just pluck. Why? Why do I pluck? The reason is because we don't want to save mucosa. It's called nasalization of the ethmoids. Means you remove the mucosa. Why? Because when you keep the hadad, it might actually be over secreting. Huh?
It might not adhere with the surface.
Exactly. And it's secretory mucosa, right? So you don't want mucosa over mucosa. Okay, let's see. I'm waiting for the debrider. The suction, please. Okay, here we are. I'm now going to take off that posterior ethmoid, go into the sphenoid sinus immediately. I'm not showing the technicalities of this because anyway, I'm going to show it to you in the next case. The idea is to show how we're going to close this leak with a completely new technique. So that's a skull base. Irrigate. Now I'm going to do what is called the Jula technique.
Sections.
So this is the choana, and you can see here that I'm just going inside posterior ethmoid. That is the skull base. Give me the debrider, please. Now I'm going to open up the sphenoid sinus here. Wait, my dear. Ma, block nanikiramma.
Suction pressure.
It's not working at all. See, I'm not able to debride. The most important quality of a ENT theater is a good suction. So even the debrider can be a little different from Medtronic, but then I think the suction makes all the difference. My first investment in Hyderabad was 10 good suctions. You can see that's the lamina papracia. You can see the Onodi cell. Can you all see the Onodi cell there?
Yes.
The optic nerve very clearly?
Yes.
Okay, that's very clearly seen there now. I'm going for the sphenoid sinus. So, if you look at the sphenoid, don't ever think it's a sphenoid, because if you see something straight like this, it's not the sphenoid sinus. So, and another thing is the base should not be seen. Of a sphenoid sinus, the base should not be seen. These are all the two, frontal, posterior table should be seen. In a sphenoid, the base should not be seen. It should be like a cave. Now is the Jula technique. See that? 1, 2, 3, 4, 5, 6, 7, and 8. 1, 2. See that superior turbinate coming into view. Can you see that? Now
Yes.
change the debrider towards lamina papracia. And this is the movement of the for the superior turbinate. 1, 2, 3, 4, 5, 6, 7, and 8. 1, 2, 3, 4. Now we can don't irrigate. That's the sphenoid sinus. I can see that. Now, sometimes for the sake of juniors, of course, there are no juniors watching in Goa, I know. But maybe online, some of them are watching. You can see there's a slit like opening there. So I'm just going to go inside that slit like opening. Or if you can't, the best is use a sphenoid ball probe. See here, I'll show you how to use the sphenoid ball probe. Suction. Now you can see here, this is the ball probe. All of you get this ball probe. It's very, very important. It's available again with Santosh Surgicals. It's a malleable ball probe with a ball tip. It's a lovely instrument for the sphenoid sinus. So here we are. I'm just going inside. Just for the juniors, I'm demonstrating this. Of course, I would have done it without it. You can see here. Just palpate, it'll go inside. See that? It's gone inside. 1, 2, 3, tap. It goes inside. 1, 2, 3, tap. It goes inside. Keep that probe like this. Okay, see. My probe is hanging like this. Then you take a Blecker. Now, when I go inside, I should take it out. 1 second. 1 second. 1 second. 1 second. 1 second. Oh, it's bled. Okay, take it out. Okay, actually, it's yeah. I can see the bubble. That's the bubble sign of Stamberger. Any sinus you open, find a bubble. That means you open the sinus. Now I'm just going inside. You can see that I opened the sphenoid sinus. Can you all see that clearly?
Yes, yes.
Now what I will do is I'll use a debrider. I'm going to widen that sphenoid sinus till the level of the planum. So that's don't widen it inferiorly because the vascularity of the Haddad flap will be compromised. So go like this. See here, that is the sphenoid sinus here. And then that's a Parsons ridge. The Parsons ridge separates the
Posterior ethmoid from sphenoid.
On the scope.
Sometimes the Parsons ridge is very thick. So how do you deal with it? The best way is to make it into a drill mode. See here, make it into a drill mode. So see here.
Ready.
Now I've changed it to a drill mode. Irrigate. Irrigate. Okay, there are two ways of doing it. Number one, you can use a punch or you can do this continuous mode. Very useful mode for if the Parsons ridge is thick. Okay. I can see already. You can see that. Can you see that?
Yes, yes, yes.
That looks like brain tissue. Can you see that?
Yes, yes.
Yes, sir.
That's brain tissue. Now you're confirmed that it is going to be the sphenoid sinus. Hello?
Yes, we are
Yes, sir.
seeing you.
Now I will go in for the trans-pterygoid approach. And for that, what should I do? I have to do an endoscopic modified Denker's approach. So give me a coblation now. Now, either I can do with the medial maxillectomy. I don't for a demonstration I wouldn't do that. Maybe I would do it.
Right side.
So I would like to do an endoscopic modified Denker's approach for this. So the first step in an endoscopic modified Denker would be a resection of the inferior turbinate. See, identification of the pyriform. Hello?
Yeah.
Everybody went out to the beach, ah? Goa beach, ah?
When you are
No,
here,
sir.
when Janakiraman is operate, how they go?
Everyone is engrossed with your beautiful surgery, sir. So no.
No, but how many
voice
people are
from
there
any
in
side.
Goa? How many people are there in Goa?
Around 100. And there are
100.
many on webcast.
I know, but why didn't you take me to Goa, boss?
So we wanted you to come.
Yeah, because I would have spent a good time with my friends. Anyway, it's
We will be
okay.
more than happy if you will join us.
But the problem is I don't think I can get a case in Goa to operate. So I had to be here in Hyderabad. And tomorrow we are inaugurating a hospital, health minister is inaugurating. So, Vasavi, Royal Pearl.
So I have one question here.
Yeah.
Like, do you have any suggestions of as precautions who are there as a beginner on the webcast?
What do you mean? I mean, like for what?
Because this is very critical area when they are starting with these surgeries. Many of them must be beginners on the webcast. So what you will suggest, what precaution they should take in when they are operating in this area?
I think she means the live surgery.
You need what?
Live surgery.
What?
Live surgery.
No, what is the question? What is the answer? Advice to youngsters is you have to do a lot of cadaver dissections, watch a lot of people doing,
Right.
get your own technique. For example, this is a very new technique which I'm going to demonstrate. It's a completely new technique and it needs a lot of expertise. You're going to see that. It's a lot of expertise.
True.
You just can't do it if you're just an ordinary skull-based surgeon. You're going to see that. There's something very, 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 very different which I'm going to show today. I think this will be the first ever demonstration in India, I'm very sure, of this technique, coblation. So, do you know that endoscopic modified Denkers, the first person demonstrated in India was me, in Kerala. Of course, I can tell this without a record, but actually it has a record. I came back in 2007 from Australia, and then I demonstrated that technique in 2008 in Kerala. Before that, endoscopic modified Denkers was not demonstrated in a conference. So this is the inferior turbinate which I'm actually cutting. You have a artery which is called the turbinate branch. Okay. Now I've removed the inferior turbinate. So that's the first step in my technique of endoscopic. See this, I call it the sliding sign. If you cut it, it'll slide. It's called the sliding sign. All these are kuti signs. Like, you know, some people plug that inferior turbinate without sliding. So you get half the turbinate. Elevator. So now I'm going towards the anterolateral wall of the maxillary sinus. Can you see here? When you elevate, don't go up. In Denkers, never go up. Go down. Go parallel to the floor. That's very, very important. See here. Now, once you do that, you ask your assistant to hold it. Okay. Now get the drill. Suction. Now, I am very comfortable with four-handed technique, and that too with Shilpi. You're riding a Mercedes-Benz. When you operate, it's not at all difficult to do it four-handed. Okay. Now you see here, Forex-Stenberg cannot leak. Drill. The thing is, foot switch. Okay. Now I'm using the Midas.
Irrigation.
Yeah, irrigation. Midas, please. So this is the Midas drill.
Irrigation.
You see how I'm positioning myself. The external camera can show what I'm doing. So see here, that's the lateral osteotomy. I don't have to go very far lateral. And that's the superior osteotomy. Again, I don't have to go very superior because I go superior only for cavernous sinus. See, this invention is Shilpi's invention of how to irrigate in a burr. So I think you have to show this to the audience. Again, not published. Some things we don't even publish, but it's nice. It's completely. We'll have to beg the company people for an irrigator. You see here, now it's so beautiful, it's irrigating itself. So that's the anterior piriform aperture. Now I'm just going to take this out. Now that's the nasolacrimal duct. I'm just going to thin the anterior wall of the nasal. So there are medial wall, anterior wall, and lateral wall. Can you see the nasolacrimal duct here? Can you see here?
Yes.
Yes, sir.
Anthony,
Yes, yes.
you went off, huh?
Sitting.
I
here.
have to constantly ask if Anthony is in the beach or in the hall. Elevator. Another elevator.
Even if it is 12 o'clock, I will not go from here because you will make the whole world know I'm not here.
You're right, Anto.
Your elevator.
No, it's okay. I'm using the other side, cat's paw. See, we have two sides of an elevator. I call this the cat's paw. So use this to the best of your abilities, the cat's paw. So something like, of course, you have the regular cat's paw in head and neck surgery, but I have named this, the other side of the elevator as a cat's paw. Now you can see here. Okay, now I'm going to now drill this area and get at the nasolacrimal duct for you. Now, drill. Now I'm just going to drill that area and get the nasolacrimal duct. Because never injure the orifice of the nasolacrimal duct. You will land up with epiphora. So far, any doubts, Anto?
Yeah, no. You are doing fine. You got a clear picture. Only thing is you should have brought the Royal Pearl paramedicals also here.
Loyal Pearl?
Theatre team here.
Theater?
Theatre team.
No, I am very comfortable. Actually, this is also looking like Royal Pearl only for me. I don't find any difference now in Hyderabad. That's the nasolacrimal duct being cut. See, this is actually the 4K camera. That's why a little difficult picture. But actually, I love the spice rather than the 4K. This is something I've been telling even the Carl Stores people. And I also advise Harsha not to get it, but somehow he was behind the 4K.
Stores 4K.
Okay.
Stores for.
Is it
I mean
stores
the stores 4K only.
Yeah.
I personally feel that the spice is the best. At the moment, the S camera is the best. It's not called the spice now. It's called the S camera.
Slip ready.
Now give me a debrider, please. Now you see what is happening now. That's the middle turbinate. Can you see the middle turbinate here, please?
Yes.
Debrider. Now you see here, I'm now going to.
Wait, that's combination. That's combination.
You can see that's the nasolacrimal duct which is cut.
Ready.
When I have Beulah, I have Anandi, who are actually from Trichy only. So my staffs are from Trichy. Shilpi is there. What more you want?
That's what I was wondering.
Yeah, see, that's
That's what I told you, man.
see Beulah, Anandi. We have
Beulah
three
Anand
staffs.
only I'm telling.
Yeah. Beulah is there. That's it. After that, I don't have to worry staff wise. Same way, Harsha is there. Shilpi is there. What more I want? I have Royal Pearl here. Converting this into a home place. Of course, Avinash also.
Action.
But it
Now,
poor thing built such a wonderful home.
yeah, boss.
Royal Pearl here.
Really, boss. I missed you yesterday. Seriously, I missed you yesterday. Okay, that's nasopharynx. Now, this is the posterior wall of maxilla. The next step is to resect a part of the middle turbinate. You have to resect a part of the middle turbinate because you can't have the middle turbinate and do the Haddad flap. Now, here we are. I'm going to resect it. Is it the Karl Stoss one or? So I'm resecting partly the middle turbinate. Can you all appreciate it, please?
Yes.
So that's a partial resection of the middle turbinate. I'm very careful. The reason is I don't want to cut the sphenopalatine artery. Again, actually, Anto beautifully said, why are you bothered about this side? See the kind of observation he has. Now give me a scissors again. I'm going to resect a little bit more because I want a better flap. Very narrow. Let's see. Hey, the scissors is not even opening.
Second ready.
Very narrow space. Ah, now I got it. Now, what I'm going to do now is something different now. This is what is going to be different in this case. So, any of my friends are in Goa. I don't know who are all in Goa. So maybe some people can come and actually say hi. I'm really wondering who are all there in Goa. Should be a lot of friends over there. I am very jealous.
Everybody is your friend only, man.
Okay, give me a good irrigation. Now, see now. Now I am not going for the this one trans-pterygoid approach. What I'm going to do now is to take the hard flap. See now, infiltration. This is deviation from normalcy. Usually we do a cross coat or we put in a
Small section ready.
fat fascia. Now I'm doing neither. This is again my own thumbprint. Knife.
Ready.
So those of you who have not seen this can go back and just read the paper. Of course, honestly, I'll tell you from my heart, I didn't read this paper and do it. I did it without the knowledge, but you can say this is called transposition of the hard flap. It's called transposition of the hard flap. I can see here. Now that's the nasoseptal flap. Dr. Mahati has become my close friend. And actually, she has replaced Bala. Bala is watching from Trichy. He's very angry with me.
Definitely. I think this association with you is so long years. But suddenly,
You see, now Satya has got that privilege. What to do? Okay, right. Now you see there's a little deviation there. So what I'll do is I'll not raise the hadad here. Okay. Now what I'll do is I'll go in for a come, hold it. So this we published. Putty. Now give me a knife. Or I can use this as a knife. I'm going to do what is called the window technique. It's called the window technique. This you can see. Uday Chanukya published it. I'm using the elevator itself as a knife. You can see here. That's how I designed my elevator.
Is it ready?
Okay. Now give me a
Okay, बाहर आ जाओ.
okay. So Okay, now scissors. I honestly believe that I think as surgeons, young surgeons, at least if there are postgraduates there, you should have your own original technique. Don't just follow like a goat, some person because they have published or something like that. Don't do that. This is something which I honestly believe should become part of your religion or part of your blood, RBCs. Don't, because some book gives, he's also a person with the same brain, 1.5 kgs. So why not you also form a new technique? So this is the quest for research. Okay, if somebody has done something, what should I follow the same guy? So this always comes into my mind.
This window, Janakiraman,
Yeah.
actually this window allows you to elevate on the concave side, like your classical teaching. Always elevate on a concave side. So you make a window on a
Hold.
deep septum, you can.
Hold.
Yeah. So what I'm trying to do now is I'm going to now elevate the bone.
There's a come.
No, it's okay. It's okay. Now you see, this is a very tricky area, very, very tricky area. This is a convex side. Never elevate at the side of the, give me a big, thick scissors. Thick scissors. Now you see what I'm trying to do. I'm going to take that and give a osteotomy here. Hey, this is not cutting, man. Okay, I cut it. Problem is when you cut it like this, it shears and that might be a tear. But anyway, take it off, take it off, take it off. Now I have to push this part so that I don't damage the nasopharyngeal flap. See how this is the movement. All the movements you have to observe. For the sake of juniors, very, very important. Even if you have a massive deviation, when you're taking a nasopharyngeal flap, and even the suction, you should pinch. The assistant should be good enough to pinch, because even with a small suction, you can actually tear the flap. Now, give me the elevator now. Now, let me check whether I have created a tear. No, not yet. See that, beautifully seen. Can you see that, Anto?
Yes, yes, yes.
Now, you can see that deviation didn't affect me. Neither was the packing, the trauma due to the packing affected me. So you can see that that's the floor now. Now I'm just going to take off this Haddad flap. Here we can use two techniques. We can go in for the four-handed technique. I'm going to use my scissors now. Suction, please. Thank you. Hold the suction, pinch the suction. Whenever you go in with the suction, so that's the sphenoid sinus here. Okay. Now give me a knife. Now I'm going to show you the cuts which I do for the nasopharyngeal flap. See here, I go out, go inside, and then see all these small movements are very important. See here. I'm making that cut here. This is the cut for the above. That is the superior cut, which is 1 to 1.5 centimeters below the level of the skull base. Why do I do that? Because I have to preserve the olfaction. Right. Now here is the choana. I'm just doing that cut here inferiorly at the junction of the floor and the septum. You see that? Can you see that clearly, please?
Yes.
Now what I will do is I'm going to make this cut above. That's a fan-shaped cut. Never make a cut straight here. This is necessarily a blind cut. Karao keeps telling this. This is necessarily a, see here, you put it like this, put it like this. Then you see 1, 2, 3. You are just trying to screw it up a little bit. And then see here, one cut. See, right above, I'm going right above. This is where it's going to cover the defect. So don't hesitate to go above. This is what I want to tell you again and again. So that cut was the most important cut in the Hadad, which is a slightly blind cut. Anto,
Yeah, listening.
there are no questions at all. I'm really surprised. Yes.
All the delegate doctors, if you have any questions, please raise your hands. We will provide you the mic immediately.
So really, Sun has done a great job. You know why? To make the doctors come to the venue in Goa to sit and watch surgery. That is the biggest achievement of Sun.
So it's because of you and Dr. Anthony, and all the delegate doctors here are also very academic and scientific. So
No,
more
but
than
to
us,
make-
it is credit to the doctor fraternity, I can say.
Really, really, hats off to the doctors who are watching surgery from Goa. It is like watching surgery from Miami. Elevator. Hey, not this man. Yeah, this one. Sorry.
Janakiraman, are you reminding us tomorrow we don't have surgery session?
Hello, who is it? Yeah, somebody is talking.
Dr. Anthony,
Yeah,
Are you reminding the delegates that tomorrow we don't have a surgery session?
tomorrow, of course not. Please, Goa, please. Scissors, let them enjoy Goa, boss. How many times they can watch all this again and again? But this case, I'm telling you, is worth it. I'm going to show you why. And I think this, again, I tell you, the first case to be demonstrated in India. Hadad transposition. It's called, like pituitary transposition, it's called Hadad transposition. So I always say a Hadad flap should be raised till what level? Till the pterygosphenoid synchondrosis, right?
Yes.
Okay, now I'm going to change that statement. That is where we are going to take a tangent. Scissors. Now we are going to say, no, not now. Now, can you see the pterygosphenoid synchondrosis, all of you? I'm going to show you that. And the pharyngeal nerve, that's a palatovaginal canal. Scissors, sorry, suction. Now, Dr. Anto, just have a look at it closely. So, this is actually the place where we stop the Hadad, right?
Yes.
Can you see that? Pharyngeal nerve.
Yes.
Okay, that's where we are going to differ now. Now, I'm just going to put this Hadad down. And then now what I will do is I'll go for the elevator. Now I'll go for the posterior wall of maxilla. So what is this bone? The palatine bone, perpendicular plate of just taking off that mucosa. Okay, right. Now give me a Blexley. Actually, if you look at it, if there is more red, it becomes a little maroon. It is not true red color.
Here is fairly okay.
No. If it is.
Yeah, even this Olympus 4K, it comes
Exactly, correct.
we
Now,
couldn't
Blexley.
appreciate that here, but to see it straight, we definitely see.
Yeah. Here.
Orange tinged maroon, something. Like
Correct. Now, what I'm going to do now is I'm going to show you, elevator, the sphenopalatine foramen. So here we are. I'm going to show you the sphenopalatine foramen now. Elevator. Now see here, hold Shilpi. I'm going for four-handed suction. And now what I'm going to do is to completely from here, I take a tangent. And I'm going to show you the sphenoparatine foramen here. Wait, give me a Blexley. I'll just take it off. Upturn Blexley. Irka. Any Blexley. Hey, you can't assist also, man. Hey, this is not opening also, da. This is not opening, da. Give me Blexley, normal Blexley. Okay, leave it. இதெல்லாம் இது பண்ணணும், grease பண்ணணும்டா கண்ணே. That's the nasal flap here. Okay, now give me an elevator now. Now I'm going to see the sphenoparatine artery here. Come out, my dear. Go inside. Can you see the sphenoparatine artery here, my dear friends?
Yes, yes.
Okay, now what you do is you elevate like this and give a cut here. Scissors.
Pinch the section.
Sometimes what I'll do after the surgery, I'll just talk to myself and say, Johnny, nalla pannada. Idha vandu nee mattam pannada mari pannada. That's in Tamil, patting yourself for something new. That should be there. You have to appreciate yourself when you do something different. So this is the cut which I designed. Of course, that has not been given in the paper described. Now that's the sphenoparatine artery, scissors. Now I give a cut here, superior cut. Okay, now I give a superior cut and an inferior cut above the sphenoparatine foramen. Can you see the sphenoparatine artery now, please, all of you?
Yes, yes.
Now what I'm going to do now is to cut off the So why so much of strain? Why should I take so much of strain? Why can't I do an contralateral Haddad? The idea is when you do a contralateral Haddad, you have to cut the septum, create a posterior septectomy. Point number one. Point number two, you have to connect both the sphenoid sinus, which is actually a more radical procedure. Apart from doing a Denkers. So that is why I prefer to do this. So you can see here that I'm just opening this sphenoid sinus. Of course, I will have to open the other sphenoid because this encephalocele is slightly bigger. So I would not do it a single sphenoid in this case. I want to do it with both the sphenoids. Okay. Now give me a drill. Now see here what I will do. Okay, I'm taking the drill now. Yeah. I'm taking the drill now. Hey, you're not going inside. Oh, this is white. Good. Thank you, Shilpi.
How this is compared with the S2?
S3 neuro drill. This is also good, boss. Mida is also good. Only thing is irrigation system was not there, for which Shilpi has found out a very good solution. So now in Hyderabad, I'm using only this. Lovely drill. The only drill I don't use is the stylus because I don't have a control. Of course, if you're used to any system, is good. So this area will be the area of the Greater Palatine Canal.
Understood.
Okay, cat's paw. Okay, you can see here that the most important step is don't damage the IMAX. Ipsilateral IMAX you should not damage. Can you see that? I made a window here.
Yes.
All of you.
Yes.
Yes, sir.
Now where is Phenopatine foramen? See, can you see the Phenopatine foramen here?
Yes.
So I make an osteotomy here. You understand? See that? Clearly seen. Can you see?
Yes. Yes. Yes.
Yeah. Now I make an osteotomy. There's a small cell. That could be a Harzala cell. Aguila Sami keeps talking about it. Dr. Harzala is my very close friend as well. I've opened that cell. Harzala. It's called the retromaxillary cell. Advantage of this Anto
Yes.
is that if you buy an IPC, no, anyway you need an IPC. You just need an extra attachment, that's all. Perpendicular plate of palatine bone. I am drilling off the perpendicular plate of. It's a little thick.
Understood.
Sphenoidal process is thick.
So you have two processes. One is orbital process and second is sphenoidal process. So here I am taking off the orbital process. This is the palatine lower part. Very thick. Irrigate. So this will be the orbital process. Right. Okay, coblata. I'm not bothered about the descending palatine. Coblata. That's a descending palatine.
Okay.
I'm not bothered about it.
Right foot.
Blue.
Irrigation please.
Irrigate. So that's not the vascular supply of the flap. Okay. Now having done that, so what am I going to do now? So what I have done right now is I have taken off the orbital process of the palatine bone, which is here. Suction. Can you see the sphenopalatine artery going inside the flap?
Yes, yes.
See, going inside the flap. Oh, what a beauty. Elevator. Anto,
Yeah,
have you seen this before? First time?
I've seen this in mucor cases.
No. But this flap, I'm talking about the Haddad flap,
With the supply now.
going till the level of the IMAX.
We stop short just lateral to the
Yeah, that is what. That is what is the difference, no, in this case. So that's the sphenopalatine artery. See that? That's the sphenopalatine artery now. Now what has happened is that I have now raised that bone orbital process. You see that? Can you see? See, that's IMAX here. This is IMAX here. This is the sphenopalatine artery. That's the descending palatine artery. Okay. Now what I will do is I will just push this Haddad flap. See here, this is the step is the most important step. This is what is called Haddad transposition. Okay, now give elevator. Hold, my dear. See here. Now this is the most important step of Haddad transposition. See here. Now I go like this. I hold my cat's paw. I put it inside the maxillary sinus. See, that's the palatovaginal canal. Can you see that? All of you.
yes,
I'm
yes.
cutting the pharyngeal nerve. Can you see?
Yes.
See the pharyngeal nerve.
Along with that, there will be a small artery, no? Pharyngeal branches from the
Yes.
On the floor.
Now you see, what is happening is that I am now transposing this Haddad flap along with its vessel. This is descending palatine. Anto,
yeah.
see here. Now that's a pharyngeal nerve and the artery, as you said. You will have the median nerve here. Now, what you palpate back? What you palpate back is the pterygoid wedge. The posterior boundary of the pterygopalatine foramen is the
pterygoid wedge.
see the bone there. Can you see that?
Yes.
That's the median. Give me a scissors. Cat's paw. Now I'm just transposing this Haddad flap laterally. So what, see, you can ask me, what is the advantage? Why are you doing so much? See, if you have a Haddad flap, imagine there's a Haddad flap, boss, and you want to take it till the level of the frontal sinus. It's not reaching till the frontal sinus. This is the step you have to do for it to reach till there. Anywhere it will reach now. Anto,
Yeah, listening.
am I right in that statement?
Yes.
That's
Actually,
obedient. Coblation now. See the pterygoid wedge.
yeah, that's, yeah. See, instead of going
Coblation.
lateral to the palatine bone, you are going from medial side to the palatine bone.
Ah, exactly. Correct.
Because of that, you can spare the blood supply of the flap. That's an idea. Right.
Absolutely, Anto. So that's what, this is my fourth case I'm doing. Now, what has happened? See, every time we do a Stenberg, we always talk about contralateral Hadad, right?
Yeah.
Imagine the other side Hadad is very deviated. Imagine there's a big acute deviation, you are not able to take a Hadad. Then you can plan for this. Okay, Anto?
Yes. I understand.
Elevator? No, can you tell this to the audience? I mean, I don't know if some of them, sorry,
Yeah. See, the blood supply of the
irrigate.
nasoseptal flap comes from the sphenopalatine foramen.
Hey, irrigate.
The transpterygoid approach going through the maxilla, do open up the pterygoid wedge and go inside the lateral recess. If you do that, in between you have a
V2.
sphenopalatine foramen and
V2.
you got to cut the sphenopalatine blood supply. So necessarily, if you do a transpterygoid, you can't put a Hadad flap. So to overcome this, you got to do a posterior septectomy, connect to sphenoid ostium, make it bigger, do the Hadad from the opposite side. It's called a cross-coat or contralateral Hadad. But in this patient, what we have done is, yes, elevated the nasal septal flap, and with this blood supply, brought the flap parked inside the maxillary sinus. It has come along with this blood supply, and so he has exposed the pterygoid from medial side. So you don't cross the sphenopalatine now.
Come on.
So the flap is with this blood supply. Because it's with this blood supply, you can do the same side Hadad itself for the
now this is the blood supply. This is the blood supply. Can you see the sphenopalatine artery, please? See the IMAX sphenopalatine artery. Come out. This is the Hadad flap. You can see here. Very clear? All of you?
Yes.
See how beautiful the whole blood supply is here. And now I am transposing this Hadad flap into the
maxillary sinus.
Is it not wonderful, Anto?
Yeah, that's new.
Yeah.
I have not seen this before.
Yeah. That's what I told you. This will be a very good this one. Now, of course, I'm going to take a little bit of the septum.
I was wondering why you are bothered so much about the
that trauma. Correct.
septum.
I know. The moment you asked, I knew you are at that point. That's why I said you wait. Because it's the first time, I think at least India will be seeing this. Hey, go up, Shilpi. क्या हुआ भाई
Posterior septectomy, and you are going to connect both the sphenoid sinus.
Not actually, I didn't do a massive posterior septectomy. I just did only the rostrum, a little bit of the rostrum. I'm necessarily keeping that.
You can see the natural ostium of the sphenoid sinus through the flap.
Anto, there should
Yeah.
be somebody to publish all this, Anto. We in India do so much, but we never publish.
See, you just don't understand. To have a foreign publication, you got to spend about 60,000-70,000 rupees. If I have a 10 paper, who is going to spend that money? That is one
Okay.
of the main reasons we don't publish. That younger generation.
Yeah. They just want to keep and operate. That's it. Okay, this is the opposite side. Sphenoid sinus. Can you see that clearly?
Yes,
All of you?
yes, yes, yes.
Now you're started to see the encephalocele.
Yeah, this is encapsulation. If you just look whether there is any perforation in the sphenoid septum or the defect in the sphenoid septum. Maybe that is the reason that fluids we saw on the opposite side as well.
Yeah, correct. You're right. Not really. Okay, drill. See how beautiful the exposed. Boss, I'm telling you, this is like lovely, juicy. Apple. Kashmir apple. Now what I'm going to do is to take off this keel.
What happened?
On the scope.
Anybody has got any doubts, please ask them to ask the question. Very, very interesting case, boss. This is like, not the usual repair. Usually what we do, fat fascia come out. I mean, that's all. Okay, fine, routine. You've been seeing it. What's new about a demonstration?
On the scope.
I think this should be on the YouTube. And if somebody publishes it, then we can at least tell. Same how I did the orbital transposition. It was on YouTube. After many years, it was published by Castelnuovo.
Recently, we did the orbital transposition for a lateral frontal mucosa.
I can't hear you, Anto.
Recently, we did a orbital transposition for a lateral sphenoid mucosa.
Oh, frontal leak. Boss, I did it long time back. And actually, I didn't publish it. That's a Vedian. You can see that's a Vedian. Now, for a lateral recess leak, you have to go and drill the pterygoid wedge. Can you appreciate that, please?
Yes. Only for this, the transposition of the other is required.
Yeah.
On the scope.
So we have three kinds of VR lines, VR1, VR2, VR3. It all depends on how deep the recess is.
Okay, I'm tired.
You're tired?
I'm
No. This is tilt. Clockwise. Yeah, that's fine. Madam, this is a landmark surgery done from Hyderabad. Thanks for the wonderful anesthesia.
Now I understand.
You're a deadly guy, man.
Keep complimenting anesthetist.
No. I compliment when that's bleeding. Now, honestly, there's no bleeding. When there's bleeding, I'll say super anesthesia. Then they'll understand. But this time, honestly, there's no bleeding. Hey, you know everything of me, man. The problem with you, Anto, dangerous fellow.
The respect is mutual, man.
Can you see the brain tissue there?
Yes.
photo
Can you orient it with the
This is the keel. This is the keel.
no. I kindly orient with the carotid artery. That level of the carotid artery.
Yeah. Now I'm just, suction, please. Suction. Now you can see beautifully. This is the, sorry. This is sphenoid sinus. Can you see that's a carotid artery here? Can you see that?
Yes.
Hey.
Rival carotid.
Suction. Suction blocked, See how beautiful the sphenoid looks. Whenever you remove the mucosa of the sphenoid sinus, it will bleed. Always remember this. Because it is highly, that's only cell.
Yes. Only with the
Optic nerve.
nerve. Yes.
So below will be the
Carotid.
carotid, correct.
I didn't get the doctor.
No need. Give me the J curette. Now I'm going to take off this mucosa. This is all brain. Now the most important thing is to identify the V2. See here. Now this is the median here. This is the median. Can you see the median here?
Yes.
Canal.
Yes.
Now if I press here, you see that's the V2. Can you see the V2 canal here? Foramen rotundum.
Yes. Okay.
So between the median and the V2, this is called the VR line. This is called the VR line. Okay. Now you can see that I'm getting an end-on view of the
Leak.
leak. Can you appreciate it, Anto?
Yes. Yes.
No, give me a Blexley. Beautifully seen leak now. So, when I do the, who is going to take the Harsha? Can you wash up and take fat fascia? If you don't mind. Shilpi, come. Don't go. Immediately Shilpi will run away. See, this is very important, my dear friends. Hold. Whenever you do a Stenberg canal leak, thin off the medial wall of the V2. It's very, very important. Many people don't do that.
Bring it
I
down.
always-
Bring it down.
See, that's the V2 here. I show you the V2. Can you show? This is median, that's V2. Okay. Now I'm going to use the coblation. I'm going to show you that this is actually the brain tissue here. Can you all appreciate?
Yes.
Won't
you bring
Suction.
that V2 little low?
This is the
Hello?
V2 here. This is the V2.
Yeah.
So can you take the camera a bit little low? Dr.
Can I take what?
Sir is saying. Yeah.
will
The
you-
view.
Will you reduce the height of median canal little bit?
I can't hear you, Anto. Sorry.
The median canal's height.
This is the median canal.
Yeah. Just build up little bit. No, you get a better.
See that?
view.
Yeah. I'll do that. I'm now thinning the V2 here. That's the V2. I have to thin a little bit more here and I have to thin a little bit more here. Okay, so that restriction is gone. Puduma. Yuda. Hold on. Now I'm going to thin the V2 and the median, both. So that what happens is that Hey.
That's the level of the that goes directly towards that internal carotid artery, right?
No, the camera is coming in between, my dear friend. Okay. Can you see that very clearly? The Vidian canal, all of you?
Yes, yes, yes.
See that? I have to reduce a little bit more. Now give me the Blackesley. Now I've still not coagulated the brain tissue.
If you are coagulated, you get a little bit more space, no?
Yeah, but Allergic poidum. See the Vidian now. Very nicely seen, no? Here.
Yes, yes, yes.
Now give me a, see, usually what I do, before I do, I always take a small gauze piece and I keep that and take a photograph, then only I reduce it. These are all my kuti gimmicks. You know that, Anto?
Yes, yes. You know the art of demonstrating.
So, surgery itself is an art and create an art inside an art.
Because you have it's full of your art, man.
You can see the optic nerve, Anto?
Yeah, clearly. There's a small bone piece below that.
Yeah. I'll remove that. Give me one more gauze. Hey, you can take a photograph now. Once I. What's your name, my dear? Huh? Kavya. Kavya. Savia. Ravia. What is it? Boss, what is it, boss? I'm Shravya.
Yes.
Wow, wow, wow. I've never heard this name before. Even in names, we choose names, it should not be there at all. Even parents name them, no? Like that. Surgery also, when we do, nobody should have done this before. This is always, should be the attitude. Okay, now what I'm going to do is, you can see, now you take a photograph. Okay, now give me the coagulation.
Is it pulsating?
No, 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 no. This is dead. The neck always is very small. Stenberg canal neck is always small. Okay, ready?
Right foot.
See, I'm just trying to rise it and see. That's a V2. That's a V2 canal. Can you see that V2 canal here, all of you? See,
Yes,
that's a fundus. Can you see the fundus there?
Yes.
No, don't irrigate. Don't irrigate. Wait, wait, wait. Can you see the fundus, all of you? Beautifully seen. Now I'll rise it from above as well. Again, take it in one piece. The brain in one piece. Okay, take this, Blexley.
That's why you have not. That's why you have not removed that mucosa over it.
Yeah, exactly. Now, can you give me the coagulation? Now I'm going for the blue mode. Don't use the yellow mode because you can injure a dural vessel. Blue. Is it blue? What I'm touching is blue. Huh? Yellow. No, give me blue. Never go for the yellow mode near the dura.
Blue is that
Wow.
yes.
Can you see that, all of you?
Yes. Beautiful.
Now it's pulsating, right? See that? Can you see the pulsation?
Yes.
Okay. Now send it for biopsy. This one should be sent for see that one piece complete brain come out. What a beauty. Now give me the suction. Any doubt so far, my dear colleagues, friends? Anto, you can ask them. Nobody is talking. I think
Suction.
They are spellbound.
no, in a different way. I know. Goa Jakar.
Whether they are having the different mode or not. The different mode only. Huh? Everybody is interestingly watching you. Giri, you are talking about Goa mode. What is this, man?
The clivus, you can see the clivus. Now the problem here is that we'll have to remove all this mucosa. See the Vidian. Can you see the Vidian here?
Yes.
Now,
Actually,
can you give me
a no.
That's a Vidian, yeah, Vidian now, yeah. Give me a J curate.
It's not the canal.
Now I'm just going to take off this. That page are ready. Harsha is super fast. Now, suction, I'm going to start my drilling on the. Can you see the video now, all of you? Where it goes, this should be the carotid then. This bulge should be carotid.
Yes.
Okay. Now give me the coagulation. Yeah. Coagulation. I'll remove that mucosa. I can't leave it like that. Hello. Hey, Tanni.
It's like liver muscles.
Hey, don't.
Body side.
That's clivus. Hey. Frozen elevator. Can you all see the fundus? All of you?
Yes. Are you
Okay.
are you using the blue mode?
Yeah, blue only. Never use the yellow. On the dura, never, because it'll start bleeding.
But it's the water is coming.
I was using the blue only. I don't know. No.
Okay.
Don't go inside. Okay, right. Now, Rosen's elevator. Now, I'm going to use the Rosen's. Madam, another 10 minutes, it's over, madam.
10 minutes, 9 minutes.
Okay, you count. 10 minutes में हो जाएगा.
मुझे भी तो बात करना.
Shilpi, see man. Okay. Rosen's elevator, please.
Should not have mirror. They are very close to me too.
Can you see that, please?
Yes, yes.
Wow.
Just
Can you see?
Yes.
That's the dura. So that will be the interlay technique if I put it here. Of course, I don't have to do that because I have a beautiful hadat. Okay, give the Surgicel. Very small Surgicel, please. Quick. Suction. Surgicel. Hey, I want something to eat. I'm feeling very hungry. I'm having fever actually. That's a carotid artery.
Yes. Beautiful.
No coconut water. I'm having. Yeah, just give me some juice. Carotid artery. Yeah. Give Surgicel. Kudu. Chinnadu kudu. No watermelon. Just give me something. It will not cause a milk or something like that. Hot tea, something. Give me J curate. So the next case is the AFRS. We are going to discuss something very new in AFRS. That also will be a beautiful case. Now this is actually called the inlay graft. That is between the arachnoid and the dura. If you put that inlay, it should stop. Most of the times it stops. And that bleeding also stops when you put the Surgicel. That is actually to prevent bleeding. I see how beautifully it stopped that. Okay. Can you see that very clearly? Now give me the fat. Fat, please, quick. Kutti fat. No, this is too big, man. Hey, आधा. इसमें तो ना. Okay, give me J curate. Now this is what is called the dumbbell fat technique. I'm just going to put this right inside. थोड़ा बड़ा है ना? No problem. I'll keep it as onlet. Give me a gauze, small gauze piece. See, the best way is not to use a ball probe. Never use a ball probe, my dear friends. It will come out. So use a very small lint. No, even smaller than this. Use a very, so these are all the small tricks. See here. Now what you do is press it like this. Press it nicely. Some of the fat will go inside. The best way to do the dumbbell fat. If you use any instrument, it will come along with that. Yeah. See, I'll tell you one thing. Shilpi says thoda sa thread hai.
Cotton induces more fibrosis.
Previously, when CSF leak repair started, if you look the history of CSF leak, they used gauze piece only to close because cotton induces massive fibrosis. नहीं कुछ नहीं है यार. You should use a neurolint. Acha? Okay, right. Give me a small fascia. You have a fascia? Chota fascia hai kya? Now I'm going to do what is called the trial Hadad flap. See how beautiful it is, boss. Anto,
Yes, yes.
ipsilateral Hadad, boss. Ipsilateral Hadad. Wait. Hold more. Hey, pinch the suction. So we'll be discussing a lot of new things in AFRS.
Red color bag le irukuma.
Leave a little bit.
Boss, if I bring your bag, so you should send. Everything is in the bag.
How's it, Anto?
Wonderful.
Now give me a little fascia. Small fascia. This. Cut karo. See, if you do this, there is no chance of recurrence. How can it recur? No way. Now, give me the elevator. Now, you see here, I'm just elevating it. See, this is the trial Hadad. I always try to elevate the trial Hadad like this. Okay. Don't just keep the Hadad and come out. Now, where is that, this one? Fascia kahan hai? Maine diya na? Photo. Now you see, I'm just keeping that fascia. J-curate. The best instrument for fascia is J-curate. So each one, you should know what instrument is good. Simply, people will be struggling with ball probe in the fat. Actually, it will keep on coming out.
Ready?
Can you see it's completely closed?
Yes. Yeah.
नहीं कुछ नहीं. Okay, thank you very much.
Fantastic.
What a
Can we have
beauty.
that?
Yeah, outside camera. Outside camera. Anto, are you
I hope
seeing?
you could hear the clap, sir, after your surgery.
Thank you very much. It's all a pleasure seeing people in Goa watching surgery. Great. And that too, Anto stuck to the chair. It's the greatest thing, achievement. So can you pan that camera so that I can see the hall? The person having the camera there? Because I think they are lying. Nobody is there.
You
Wow.
can see now, sir.
Now I know. Oh, sir, how are you? I can see a lot of, yeah, all my friends. Wonderful. Wow. Fantastic. Goa mein itna log. Bahut badhiya. Hi, sir. So sweet. Thank you so much. I hope you enjoyed the specialty about this case. Sir, kya sir?
It's amazing to see your surgery, sir.
सर आपके आशीर्वाद सर आपके आशीर्वाद बहुत धन्यवाद सर आप आने के लिए बहुत धन्यवाद थैंक यू so we will break for some time for the next case. Would you like to have the next case or would you like to say goodbye? Because Goa, I don't want to force you. What is your take? What is your take for the next case? You want the next case or not?
Yeah,
Yes, sir, we want.
Yes, sir.
Everybody
you.
is anxious and there was a
I
pin
am,
drop.
I am
channel.
absolutely spellbound seeing the audience from Goa talking about next case. Okay, fine. The next case will definitely be a treat. We are going to do a draft 3 and I'll tell you the simplest way to do it. So that will be the easiest way for any junior, any, mid-level ENT surgeon to learn. Simple technique to do a draft 3. So that is the plan for the next case. Thank you. We cut here and come back after 20 minutes. I'm going to take some little dinner. Thank you.
Some
Thank you,
people are
sir.
interested to
See
see
you
you
soon.
without mask, if it is possible.
Sure. I am ready. Whatever.
Take out your mask.
Oh, mask. Okay. Why, boss? To see my daddy.
That's your style.
The
Yeah,
pin
what is
drop
the-
silence was because people were so engraft into your surgeries.
Hey, raise the voice. Raise the voice here. Thoda voice raise karo. Sir, what is it?
When everybody was so much engaged into the surgery, and seeing your surgery, so there was a pin drop silence.
Thank you, sir. Thank you. It is actually this surgery. Again, I'm putting it on record. Will be the first, at least in the world, to be demonstrated. Ipsilateral Hadad for a Stenberg canal leak. That I put it on record.
Post-op lumbar drain is required.
Not necessary. This is a low pressure leak. See, basically, many people talk about high pressure leak. High pressure leak. I don't know why they talk about high pressure leaks at all. See, there are some cisterns of the brain which are basically low pressure cisterns. Basifrontal cistern is a low pressure cistern. Stenberg canal can be because of high pressure. It's okay. But then you'll have to have the other signs of high pressure like papilledema. You should have empty sella. You might have a tortuosity of the optic nerve, perioptic space widening or things like that. There's nothing like that in this case. So it's not high pressure. So you don't need a lumbar drain. Lumbar drain is given only when there is a high pressure, proven high pressure more than, sometimes it can be a fallacy also, more than 60 millimeters or centimeters of water. If you have, along with that is one criteria. Second criteria is if there is 2 cisterns open, then it is a high pressure. So basically, other than that, we don't do CSF diversion. CSF diversion is not required. It's not required for low pressure leaks.
Post-operative care, anything specific we need to
Post-operative,
care, anything specific we need to do?
for this patient, sometimes they add Livipril, that is anti-epileptics. Usually because we handle the brain, the dura, anti-epileptics given over a period of 1 week. Then sometimes if you feel there's a little high pressure, then you can put astazolamide, Diamox you can give for a week, strict bed rest, laxatives, then fluid diet, semi-solid diet for a week, and then he's back to his work. That's it. So basically 1 month of less strain. But this case, I don't expect any problem at all.
When the
Nasal
when the abdominal girth is more, we prefer them to lie on the sides,
Lie on the sides.
not lie flat supine. When you lie
Actually, I'll tell you one thing. See, there is a study which says that the CSF pressure, when you study while lying flat, is around 10 to 20 centimeters of water. If you lie on one side, it becomes 16 to 30 centimeters of water. So basically, we don't advise side lying in CSF rhinorrhea. This is, you can read any literature. What I'm talking is evidence-based medicine. So when you lie straight, the pressure is around 10 or 20. But if you lie on one side, automatically CSF pressure increases to 16 to 30. So what if the abdominal girth is high, you try to get the weight down by elevating the head. If you elevate the head, the diaphragm goes down. So that is how we actually reduce the pressure, not by the sides.
Sir,
Good question. Very good question.
Nasal irrigation required post-operatively?
Never do nasal irrigation for at least let it crust. We want crusting. We want fibrosis. Maximum we can do is salt spray. I mean, any spray. But I never advise an irrigation for a CSF, post-CSF leak, because 2 things. One is when you irrigate, the patient will say, oh, there is some liquid coming out. So we'll get confused whether it's residue or recurrent leak, or is it the water coming out? So that also we don't know. So I don't advise anything, any irrigation for at least 15 days. After the Hadat usually takes in 48 hours. If we put free grafts like fascia, fat and all, better to avoid for 7 days anything inside.
Tissue seal, is it required, sir?
T-seal, nowadays I don't even use, boss. I don't use T-seal at all. I use Surgicel and I allow it to crust. T-seal I hardly use because that's around 10,000 rupees extra. No, why do you want to charge the patient? It's a placebo. I hardly use T-seal nowadays.
So any difference between inlay and underlay?
There are three kinds of grafting. One is called the underlay, second is called the interlay, third is called the onlay. So inlay is between the arachnoid and the dura. Interlay is between the dura and the bone. Onlay is between the bone and the nasal cavity. So there are three kinds of grafting. So we prefer to do it in all three layers, whatever leak it is, except for very minute cribriform leaks, which are generally very low pressure leaks. So what we do is we put Surgicel first as the first layer always because it prevents bleeding. And we put fat as a dumbbell fat, which actually goes in for a inlay as well as an onlay. So it's a beautiful, it'll take the shape of a dumbbell. Then of course, Hadat flap or the nasoseptal flap will be the final layer, which is an onlay, always onlay, always onlay. Facial lata, we can do it, all the three layers we can do. If you're not doing this repair, we can do 3-layer facial lata graft. That is what is being done by Professor Castelongo. And he does 3-layer fascia graft. Of course, this leak doesn't require 3-layer fascia graft at all. So, so that's the answer to your question.
Sir, if there is no post-op leak, is scan is required again?
No. No. Why do you want a scan? You don't need a scan. Only if you have severe headache and you're suspecting pneumocephalus. So usually patients will have severe headache post, that's why, see, I'll tell you, I never open the sac until my repair is complete. So the minimum amount of CSF should go out because CSF leak per se can cause headache. So don't cut off the sac or meningocele, make a lot of CSF come out because that's not science. You have to do it last, like how lateral canal, cholesteatoma is not removed if there is a dehiscence. So we remove it, immediately put on the bone plate. Same thing in CSF leak. Don't cut off immediately. Do it the last. Then the moment I did it, immediately I did that is a Rosen's elevator and immediately put a graft. Minimum amount of CSF leak should be there. When do you take a scan? Only if the patient goes in for severe headache or sometimes blurring of vision or sometimes double vision. We have seen everything like that. So this is because of pneumocephalus. If you have pneumocephalus, then you need to take a CT scan.
So, good evening, sir. I'm Dr. Shankar Subramanian. So,
Hi, Shankar. How are you?
Good, sir. Good, sir. So, regarding the pneumocephalus, if there is a lumbar drain placed, so how can we differentiate whether it's because of lumbar drain or because of incomplete closure?
Very, very good question. Actually, when you place a lumbar drain per se can produce a pneumocephalus. Okay. If you have a leak, again, that also can produce a pneumocephalus. Now, what you have to do is when you have a pneumocephalus, close the lumbar drain. The first thing you should do is close the lumbar drain because that you don't want to suck the air. So close the lumbar drain and then check serially with a scan whether that pneumocephalus is increasing or not. If it is increasing, it's called the ball valve effect. It's called the ball valve, that my air going in, not coming out. Then you have to revise your leak, repair. Usually pneumocephalus settles by itself, just by positioning, high flow oxygen. It just generally, settles. But I have seen massive pneumocephalus where we had to do a decompression craniotomy. That level I've seen, the whole frontal lobe filled with pneumocephalus. That usually occurs in trauma, post-traumatic, massive crush injuries. You have huge pneumocephalus, then that's a problem. But to differentiate it, close the lumbar drain, close it, watch, and then see whether the pneumocephalus is increasing or not. If it increases, then it's because of the repair. If it's not, it's because of the lumbar drain. I hope I answered your question.
Yes, sir. There are two more questions, sir. One
Yeah.
is regarding this drilling mode in the debrider. So, what is that drilling mode?
So, see, when you're having thick bones, for example, neoosteogenesis, this commonly happens in sinusitis, in allergic fungal rhinosinusitis, fungus, thick Parsons ridge, all that. So these, you don't have a burr. Every time you don't have a burr, right? So in those instances, you can convert this this debrider, which is called the alternating mode, which we use usually, into a forward mode. Forward mode means it'll revolve like a burr, and you can burr off that bone. But the advantage of using the forward mode is that still it will preserve mucosa. Mucosa will be preserved even in forward mode. That is the beauty of the forward mode of the debrider.
Does it come in this Medtronic, sir? Or
Medtronic.
so in the next case, it will be nice if you show that camera also, sir, regarding the settings.
Camera?
Outside camera.
Outside camera.
Yeah. Sure. We'll do that. For the next case, give me around 20 minutes. I'll just finish my dinner and come. Okay? Right?
Sure, sir. Thank you.
Thank you. I will cut the projection.
Janakiraman,
Yes, Santo.
it's a fantastic demonstration.
Thank you, Anto. Always I shiver when I demonstrate in front of you.
But you are doing it for the past 35 years, man.
And still I shiver. Good. Thank you. Thank you, Anto.
Go have your dinner fast and come, everybody. Eager.
You have something to drink? Hey, Purva.
miles from Earth. Any closer or any further, and we couldn't exist in our present form. So powerful, it gives off more energy in 1 second than all Earth's people have used since the beginning of time. The Sun, miraculously positioned around 97 million miles from Earth. Any closer or any further, and we couldn't exist in our present form. So powerful, it gives off more energy in 1 second than all Earth's people have used since the beginning of time. It makes the wind blow, the currents flow, the rain fall, and every living thing grow. Above all, it is totally reliable. It has been here from the beginning, and it will be here for millions of years to come. And it is because of this that we named our company Sun Pharma. And why, since our inception, we have striven to achieve the same uncompromising reliability and level of trustworthiness of the star we depend on. From humble beginnings in 1983 with just 2 employees and 5 psychiatry generic pharmaceutical company in the world, selling over 2,000 products in 150 countries. We employ over 30,000 people, representing over 50 cultures in 6 different continents. Every year, we sell over 30 billion doses, covering a wide range of treatment alternatives, from cough and cold to cancer, to reliable ARVs that give hope to millions of food sufferers on a daily basis, to a solution for psoriasis, to dermatology, and so much more. And significant investment in R&D beginning 3 decades ago enabled us to make technology our key differentiator, and the faster, robust, yet technically complex products designed for diverse markets across the world. Today, we have a team of 2,000 world-class scientists working in state-of-the-art R&D centers spread across the world. We consider it paramount that wherever in the world we research, develop, manufacture, test, or distribute our products, quality will always be of the highest standard. Some, there is no substitute for quantity. Based on core values for reliability, quality, innovation, trust, and consistency, we are able to deliver on our vision, reaching people and touching lives globally as a leading provider of global disease. And much like the star that depends on it, we will rise and shine together to the benefit of everyone. Sun Pharma, reaching people, touching lives. The Sun, miraculously positioned around 97 million miles from Earth. Only closer, only further, and we couldn't exist in our present form. So powerful, it gives off more energy in 1 second than all Earth's people have used since the beginning of time. It makes the wind blow, the currents flow, the rain fall, and every living thing grow. It is totally living. We have from the beginning, we will be here for millions of years to come. And it is because of this that we named our company Sun Pharma. And why? Since our inception, we have striven to achieve the same uncompromising reliability and level of trustworthiness of the star we depend on. In 1983, with just 2 employees and 5 psychiatry products, our company has grown from strength to strength to become the 5th largest generic pharmaceutical company in the world, selling over 2,000 products in 150 countries. We employ over 30,000 people, representing over 50 cultures in 6 different continents. Every year, we sell over 30 billion doses, covering a wide range of treatment alternatives, from cough and cold to cancer, to reliable ARVs that give hope to millions of food savers on a daily basis, to a solution for psoriasis, to dermatology, and so much more. And a significant investment in R&D beginning 3 decades ago enabled us to make technology our key differentiator and the faster, the robust, the technically complex products designed for diverse markets across the world. Today, we have a team of 2,000 world-class scientists working in state-of-the-art R&D centers spread across the world. We consider it paramount that wherever in the world we research, develop, manufacture, test, or distribute our products, quality will always be of the highest standard. Some, there is no substitute for quantity. Based on the core values of reliability, quality, innovation, trust, and consistency, we are able to deliver on our vision, reaching people and touching lives globally as a leading provider of building disease. And much like the star that depends on who, we will rise and shine every day to the benefit of all mankind. Sometimes, reaching people, touching lives. The sun, miraculously positioned around 97 million miles from Earth, only closer, only further, and we couldn't exist in our present form. So powerful, it gives off more energy in 1 second than all Earth's people have used since the beginning of time. It makes the wind blow, the currents flow, the rain fall, and every living thing grow. It is totally limited. Being here from the beginning, it will be there for millions of years to come. And it is because of this, we named our company Sun. And why? Since our inception, we have striven to achieve the same uncompromising reliability and level of customer-use on the star we define. Humble beginnings in 1983, with just 2 employees and 5 psychiatric members, our company has grown from strength to strength to become the 5th largest generic pharmaceutical company in the world, selling over 2,000 products in 150 countries. We employ over 30,000 people, representing over 50 cultures in 6 different continents. Every year, we sell over 30 billion doses, covering a wide range of treatment alternatives, from cough and cold to cancer, to reliable ARVs that give hope to millions of food savers on a daily basis, to a solution for psoriasis, to dermatology, and so much more. Our significant investment in R&D beginning 3 decades ago enabled us to make technology our key differentiator and develop a faster, robust, yet technically complex products designed for diverse markets across the world. Today, we have a team of 2,000 world-class scientists working in state-of-the-art R&D centers spread across the world. We consider it paramount that wherever in the world we research, develop, manufacture, test, or distribute our products, quality will always be of the highest standard. Some, there is no substitute for quantity. Based on the core values of reliability, quality, innovation, trust, and consistency, we are able to deliver on our vision, reaching people and touching lives globally as a leading provider of living disease. And much like a star when it depends on who, we will rise and shine every day to the benefit of all mankind. Sun Farm, reaching people, touching lives. The sun, miraculously positioned around 97 million miles from Earth, only closer, only further, and we couldn't exist in our present form. So powerful, it gives off more energy in 1 second than all Earth's people have used since the beginning of time. It makes the wind blow, the currents flow, the rain fall, and every living thing grow. Above all, it is totally reliable. It has been here from the beginning, and it will be here for millions of years to come. And it is because of this that we named our company Sun Pharma. And why, since our inception, we have striven to achieve the same uncompromising reliability and level of trustworthiness of the star we depend on. From humble beginnings in 1983 with just 2 employees and 5 psychiatry products, our company has grown from strength to strength to become the 5th largest generic pharmaceutical company in the world, selling over 2,000 products in 150 countries. We employ over 30,000 people, representing over 50 cultures in 6 different continents. Every year, we sell over 30 billion doses, covering a wide range of treatment alternatives, from cough and cold to cancer, to reliable ARVs that give hope to millions of AIDS sufferers on a daily basis, to a solution for psoriasis, to dermatology, and so much more. Our significant investment in R&D, beginning 3 decades ago, enabled us to make technology our key differentiator and develop a basket of robust, yet technically complex products designed for diverse markets across the world. Today, we have a team of around 2,000 world-class scientists working in state-of-the-art R&D centers spread across the globe. We consider it paramount that wherever in the world we research, develop, manufacture, test, or distribute our products, quality will always be of the highest standard. At Sun, there is no substitute for quality. Based on our core values of reliability, quality, innovation, trust, and consistency, we are able to deliver on our vision of reaching people and touching lives globally as a leading provider of valued medicines. And much like the star our planet depends on for life, we will rise and shine every day to the benefit of all mankind. Sun Pharma, reaching people, touching lives. The Sun, miraculously positioned around 97 million miles from Earth. Any closer or any further, and we couldn't exist in our present form. So powerful, it gives off more energy in 1 second than all Earth's people have used since the beginning of time. It makes the wind blow, the currents flow, the rain fall, and every living thing grow. Above all, it is totally reliable. It has been here from the beginning, and it will be here for millions of years to come. And it is because of this that we named our company Sun Pharma. And why, since our inception, we have striven to achieve the same uncompromising reliability and level of trustworthiness of the star we depend on. From humble beginnings in 1983 with just 2 employees and 5 psychiatry products, our company has grown from strength to strength to become the 5th largest generic pharmaceutical company in the world, selling over 2,000 products in 150 countries. We employ over 30,000 people, representing over 50 cultures in 6 different continents. Every year, we sell over 30 billion doses, covering a wide range of treatment alternatives, from cough and cold to cancer, to reliable ARVs that give hope to millions of AIDS sufferers on a daily basis, to a solution for psoriasis, to dermatology, and so much more. Our significant investment in R&D, beginning 3 decades ago, enabled us to make technology our key differentiator and develop a basket of robust, yet technically complex products designed for diverse markets across the world. Today, we have a team of around 2,000 world-class scientists working in state-of-the-art R&D centers spread across the globe. We consider it paramount that wherever in the world we research, develop, manufacture, test, or distribute our products, quality will always be of the highest standard. At Sun, there is no substitute for quality. Based on our core values of reliability, quality, innovation, trust, and consistency, we are able to deliver on our vision of reaching people and touching lives globally as a leading provider of valued medicines. And, much like the star our planet depends on for life, we will rise and shine every day to the benefit of all mankind. Sun Pharma, reaching people, touching lives.
All the delegates, just a small announcement.
The Sun, miraculously positioned around 97 million miles from Earth. Any closer or any further, and we couldn't exist in our present form. So powerful, it gives off more energy in 1 second than all Earth's people have used since the beginning of time. It makes the wind blow, the currents flow, the rain fall, and every living thing grow. Above all, it is totally reliable. It has been here from the beginning.
Mike.
Good evening to thank you to all the dignitary on behalf of Sun Pharma, Pharma Care. Thank you very much to all for your giving a valuable time, sparing a valuable time here. It's a sincere vote of thanks on behalf of Sun Pharma. So before call it a day, I would like to tell tomorrow's itinerary. So I request you all to please finish up the breakfast by 9 o'clock. After that, there are some of the suggestions from our side. We are arranging a cab for each and every cab. There will be 3 respected doctors are there. So we are arranging a individual cab. So it is a suggestive itinerary. You can visit as per your wish also. So there is nearby, it's a Mangeshi temple. So you can visit the Mangeshi temple. The temple is going to be open till 12:30. After that, you can go to the old Goa. It is where you can see the Portuguese colonies. This is known as Latin quarters. After that, you are requested to take lunch at Fisherman Wharf. We'll share you the map with each and every respected doctor. So we'll have lunch there from 1 to 4 o'clock. You all need to just
as far as Fisherman Wharf, it's a very famous joint. We already given the list of all the delegates there. So whenever you are getting a time, somebody may reach at 12:30, somebody may reach at 1:30, somebody may reach at 2:30, depending on your itinerary and the time you wish to spend at a respective place. But my request to all of you is between 12:30 to 4 o'clock, you please reach there. Once you reach there, you can just mention, I'm so and so delegate from Expert Meet Sun Pharma. They have already been briefed there. It is a very famous joint, veg and non-veg, both the kind of food is available there. So you can have the food and then you can continue with your itinerary.
Yeah. After that, sir, you all know that Goa is full of beaches. So you can go to explore the beaches like Miramar beaches, Dona, Baga beaches. So, and I request you all to please come back at the hotel by 5:30. We'll have a high tea over here. And from 6 o'clock to 7:30, we'll have a high tea. And there is a surprise program from tomorrow's evening. there is a very fabulous program is going to be start from tomorrow 8 o'clock. Yeah. It's a 4-time national award winner. It's a Idumada Kuna. It's a stand-up hypnotist. You are invited to be evening for this fun, prolific dance and entertainment program. You all are going to be mesmerized in this program. The program will start at 8 o'clock. The program is going to be last for 1 hour. So it's a very good program. So you are requested to please be here by 7 o'clock in the same hall, and you are going to enjoy.
My request to all the delegates not to miss this particular event, because Mr. Edmundo is internationally famed and he is an illusionist. And we have already communicated to him that you please go to each and every table and do that. So it is much above that normal show actually we generally see. So definitely you will enjoy. So plan your itinerary in such a way that you can get some time for relaxation and then you can come. So evening his program is going to be started at 8 o'clock. So accordingly you can plan. So whatever the itinerary we had shown you in the previous slide is a suggestive itinerary from our side. But then if you totally want to deviate this complete itinerary, fine, it is up to you, because the vehicle belongs to you for tomorrow and then you can plan your entire day for that. Morning, what we are going to do, we have invited few of the guides also, tourist guides here. But of course, the tourist guide cannot travel with you in your car because that will definitely affect your privacy and all. So we don't want that. So had it been a big buses, then it is fine. So in car, they will come here. So if you have any doubt about the Goa, so definitely you can ask them. Morning 9 o'clock, these all guides will be available here. So after taking your breakfast, contact your respective manager of Sun Pharma. They will definitely take you to the guides, or guides will come to you and he will explain you what exactly are the places, and you can ask so many queries and they can customize your plan. In between, if you want some time for shopping also, so he will extract some time for the shopping. So like that. And the evening after this program, 8 to 9, there is a program. There's going to be a karaoke also we are going to have here. I'm very sure there are some of the delegates would be having, apart from they are a skilled surgeon, they must be a very good singer also. So karaoke is definitely going to be there and you can enjoy that karaoke. And after that, there is going to be a dance floor is going to be open. I'm very sure there are many delegates who definitely have a very good dancing skills also. So definitely we'll participate in that. So that also is going to be there. And the bar is going to be open by 9:30, or that will be open by 8:30 also, not a problem. So we'll do that. So tomorrow's itinerary, though we have shown you, it's a very flexible, it's a suggestive itinerary, but you can decide and you can ask the guides also, they can definitely help you suggest.
So it is up to you, sir. You can explore the Goa as per your wish. So it is our suggestive itinerary. So
don't miss this program. This is very important. Okay. I mean,
So,
very interesting.
Very interesting program. This is going to be happen. So you are requested to please be here. You all are going to enjoy. So once again, thank you very much to all the dignitary for sparing your valuable time here and spare your experience. So thank you very much. So please enjoy cocktail dinner. Thank you very much and have a wonderful evening. Thank you.
And again, in short while, the second surgery also is going to be started. So while taking your drink or dinner, you can definitely enjoy that particular surgery also. Thank you very much.
Thank you.
Hello? Hello? Hello?
अरे वीजा को बुला यार फोन करके
Hello?
रमेश ना जल्दी आओ अटैच करो कहीं से एक्टिवेट हो गया है
May I draw the attention of all the participants?
Yeah.
Hello? May I request the
Can we start?
attention of all the participants because we are going to start the second case. Dr. Archana is with me. She
What
will
happened?
take us to the journey
Bring a
of,
movie for me.
case
Nice.
2.
Put some good movie. Bahubali. Hello, can you hear me?
Yes, sir, we can hear you.
Okay, shall we start?
Hello. Sir, Anthony sir will speak to you, sir.
Yeah.
Yes, yes, yes. Let's start.
So, Anthony, we are going to
Anthony
start.
sir is here, you are here, and all the delegates also are in the same room. But
Yeah,
Okay.
few are diverted towards taking their dinner.
Okay. So, we'll start with some theory so that we will understand the next case. So, this patient, what is the age of the patient? I think it's a 45-year-old male presenting a history of nasal obstruction, nasal discharge, and anosmia. So, hyposmia rather. And on examination, we found pale polyposis. That's what is written. I have not yet seen the patient in both the nasal cavities. So now there's a lot of development with respect to polyposis. And I'm going to talk a little bit about the theory aspects. Let us understand that cytokines are the hormones which modulate immune response. So cytokines are the main. Now, cytokines are produced by T lymphocytes. They are produced by T lymphocytes. Now, the T lymphocytes can be classified depending upon in two types, CD4 and CD8. So, in the CD4 category, so one is pro-inflammatory, second is anti-inflammatory. So, it's like that. So, they have a CD4 category, you have two helper cells. One is called the T1 helper cells and second is called the T2 helper cells. That's type 2 and type 1. So there in a body, there should be a proper balance between T1 and T2. If T2 is high, you will have a lot of, eosinophilic response, allergy and things like that. If T1 is high, there will be a lot of atopy and things like that. So this is the basic of this polyposis. I'm going to talk with respect to the current concepts. Now, if you look at the EPOS 2020 paper, they have classified this into a new classification, namely primary and secondary. In primary, it depending upon the endotype and phenotype. Endotype means it is type 1 or type 2. Phenotype is a manifestation. So, when you take AFRS, you have unilateral or bilateral. If you have unilateral, AFRS means it's type 2. So, if you are asked in an exam, What is the latest classification AFRS comes under? It is a type 2 endotype, and phenotype is unilateral AFRS. Same way, in bilateral, again, it is type 2. You have chronic sinusitis with nasal polyposis, and also bilateral AFRS. So this is the classification. Secondary only, you will have dental origin, then cystic fibrosis, all that will come in secondary. So basically, now we are classifying into a phenotype and endotype. Endotype, phenotype. Now, why this classification? Because we are directing now the mediators. For example, if it is going to be T2, what is the mediator? So it is interleukin 4, interleukin 5, and interleukin 13. 4, 5, 13. Remember 4, 5, 13. So if you block this pathway, then the development of polyposis can reduce. So this is what is called the biologics, the treatment of polyposis using biologics. So they will attack the IL-4, IL-5, and IL-13. And that will in turn reduce the eosinophilia. So tissue eosinophilia will be reduced when we attack it. So what is it that has come recently and the world is talking about is what is called the Zumabs. So we have a lot of Zumabs, out of which for polyposis we have Dupilumab. So Dupilumab is for polyposis, and then we have Omalizumab. So that for asthma, it has been used a lot in India. Now the latest treatment, of course, I've used that. It's a little expensive, but I used it in Kuwait, not here, for some patients, and they were all prescribed in UK, available as injections. So now the thing is, do we use it as a primary treatment? I usually don't. The basic treatment is to operate. So still, full house FESS remains the permanent full treatment, followed by post-operative steroid douching. We use steroid douching, and then we also, if it recurs, use Zimabs. So this is the protocol which we are following now, will be following in future for some time at least, till Zumabs take over surgery. But for sinusitis, many people are proposing use of Zumabs. So now what we will do now is we will go and read the scan. Of course, this is what is more interesting for us rather than the theory. You can see here, this is always read the scans cut by cut. All that I'm not going to, it's like, basics. I'm not going to deal with that. Septum is the midline, frontal, both sides developed. Interfrontal cell is here. Interfrontal cell usually drains into one frontal recess. So it's draining here to the left frontal recess. So this is the frontal recess. You can see that this is you can see beautifully that you have a spicule of bone, that's uncinate, going towards the lamina papyracea, and the frontal drainage is medial. And of course, this is not a soft tissue window, so I can't say double density or not. It looks more like polyposis. And this is a white frontal recess. Actually, this is another case which has been given to me. Case which was shown to me needed a Draf. That was a complete AFRS. This is the third case which we are doing as the second case. Third case will be done without demonstration. Of course, there is no time. You can see that that's a middle turbinate. Then you have to look for anterior ethmoidal artery. This is the anterior ethmoidal artery. There's a little supraorbital pneumatization, which is dehiscent. Right side anterior ethmoidal artery is not dehiscent. Now, maxilla, posterior ethmoids, that is the posterior ethmoid. Sphenoid sinus doesn't look like an onody. So that's exactly what we're going to do. I'm going to teach the juniors a very simple way, like mathematics, how to go for FESS. It's just going to be like a dance. It's going to be like mathematics. So I'm going to demonstrate that now. And we will be starting the surgery. Are you all ready? The hall is ready, Anto?
Yeah.
Okay, I'm going to wash up. So what I'm going to do is to show only one side for demonstration, and we close along with that side. And the estimated time I will be taking is around 20 minutes, just 20 minutes. I'll demonstrate one side.
Sure, sir.
So you'll have to run with me to follow my steps. I'll be demonstrating each step, and it'll be like a rapid fire session of FESS. Come on, where is my gown? My gown, please. So for FESS, endoscopic sinus surgery, I use 0-degree telescope and 70-degree. I don't have 30, I don't have 45 in my table. It's just 0 and 70. And generally, I use 0 for the whole procedure. I don't generally use any angle telescope. I don't use generally angled instruments also. It is all straight. It is all straight instruments you're going to see. And very, very, very less I'll be using angled instruments. So I'll teach you a very simple technique for the frontal. Very, very simple technique. Of course, you can follow whatever you want, like the bulla up. To me, I think all that is theory. Once you come to a level of, expertise, bulla down, all these are theory. I will tell you whatever Stamberger used to follow and what I learned from him. He usually follows the bulla down technique, not the bulla up technique. Bulla up technique is a little, more cumbersome and, working on narrow spaces. To me, I think bulla down technique is so easy. And I will show you that. Okay. Shall we go? Ready, my dear friend?
Yeah, watching.
Okay. Everything ready? Just get me a good debrider, a good suction, and a good irrigation. So we keep irrigating with warm saline, and that gives a very, very good field. Okay, let's get started. You're packed? No? Okay, let me pack. So pre-operative workup. We do a pre-operative packing. Oh, this is a jungle actually. So we always try to. This is polyposis, as you can see here. Pack.
Are you going to operate one side?
One side I'll operate for demonstration. Of course, the next side I will not demonstrate. Because Goa people will scold me. If I keep on showing surgeries, they'll scold me.
If that would have been their intention, you would not have any audience here, Janakiraman. They have not been still sitting here waiting for you to operate.
No, one side is fine. I mean, if you want the other side, yes, I'm ready.
Oh, why everybody likes dance, man. You're dancing.
Yeah, this is also one form of dance only, Anto.
Yeah, that's what. That's why they are interested in sitting here.
Lovely. I'll show you the dance. In fact,
my people from Chennai are texting me. They are waiting.
Yeah. So happy that people have come from far off. So nice. Great, Sun Pharma. Yesterday he was there with me in Trichy, and today he's there in Goa. So first of all, I always cut the hair. I call it the jungle. You have to cut the jungle. Why do I cut the hair? Because when you remove that endoscope, there might be a little, no, I don't need, just take it off. Blood which is attached to it. And then that will fog my endoscope. Scissors, please. So you can see here, when I cut, I should be parallel to the. Hey, you're in between me and the camera. Thank you. little meticulous about this cutting of hair, I can spend some time because during surgery, I can spend less time. Okay, right. So here we are. I'm going to start my surgery. Irrigate, please. So I have two people assisting me. One is Shilpi Bhatia Sharma. Second is Sri Harsha Tikka, like Paneer Tikka. Love you, Tikka. Okay. Now you can see that's the polyp, right? Beautifully seen. Now let me get started without much ado. I will tell you exactly how to start and how to proceed in polyposis. Many people, to me, I think they do the wrong movements of the debrider. See, the first step is to lateralize the inferior turbinate. First step 1. Step 2, luminization of the airway. See here, when you luminize the airway, many people, what is wrong, I'll tell you, they have your debrider like this and luminize. You should not do that. You see my elbow. See my elbow? You have to hug the inferior turbinate and your movement is up and down. See here, 1, 2, 3, 4, 5, 6. Irrigate. It's okay. Okay. So always try to luminize the airway. See here. Now you have to get the choana free. See that? So that the blood doesn't regurgitate. Now after that, I come out like this from posteriorly. You come out. And then you come like this. See, I'm hugging the inferior turbinate. I'm hugging the inferior turbinate. And my blade is directed towards the middle turbinate. See that? This is very important, my dear friends. The movement of your debrider is very, very important. Now you see, that's the middle turbinate. Now my debrider is pressing the middle turbinate and directed towards the uncinate. See, everything is important. Now see that. Now this is called delineation of the anatomical landmarks. See that. See the debrider? That's it. So having done that, a little maybe concha bullosa. So what I can do, you see, I'm pressing it very less. The debrider blade is very less pressed. Okay, so that's it. So I have almost finished the polyp dissection. Give me a pack now.
Ready?
Now the next step is don't suck like this. Never suck. I've seen many people, what they do is they keep sucking the middle meatus. You should not do that because like the tonsil, we advise them not to suck the fossa. Same way, don't keep sucking the middle meatus. Just pack it with 1,000 adrenaline and wait. So what did I do? What are the movements? Movements is up-down movement, hugging towards the inferior turbinate first, and then hugging towards the middle turbinate. As simple as that. Luminization of airway and delineation of anatomical landmarks. What is the third step? The third step is dissection of middle meatus. So it is similar to any FESS. Any FESS, you do the same thing. Anything, I'm going to do the same thing now. Now, I want the Nagashima backbiting. So you see, Shilpi is ready with the instrument because we do almost the irrigate, please. Irrigate, it's okay, irrigate. Okay, now you see here, that's Nagashima. How do I take it? 1, 2, 3, 4, 5, 6, 7, and 8. That's it. 1, 2, 3, 4, 5, 6, 7, and 8. That's it. So you see how I've bitten the base of the next triangle. And then I go like the C, ipsilateral outer canthus, go inside, rotate, downwards and backwards. So downwards like this L-shaped movement. And then you're right inside the natural ostium and you've got the maxillary sinus free. That's the horizontal part of the uncinate process. Now I'm just going to take off only that bone. See that? That is the horizontal part of the uncinate process. I'll show you the feet of the uncinate. It looks like a U. Always it looks like a U. See that? This is typical of a horizontal part of the uncinate process. Okay. Now what I'm going to do is I'm going to direct my debrider laterally. I know that's a natural ostium. Give me a rat 40 debrider blade, please. I know that's the a little bleeding. Can you control because it is not prepared? Can you give me a rat 40? Now this is the problem. This patient has got a type 3 polyposis of the maxillary sinus. So what do? Don't worry now. I will show you finally what to do. May take a little time. Because if you leave it, again, it will lead to recurrence. Now, this is a rat 40. See that? That's natural ostium. You can see here. I'm connecting the axillary with the natural ostium. Can you see that? Anto, please.
Yes, watching.
Okay, don't bother about the maxillary sinus right now. Don't bother about it. Don't change to the angle telescope. Many people at this point they change. You're going to waste time. Don't do that. Okay, now the next step is zero degree telescope, and this is the upper part of the uncinate process. You see here, I'm going back, making it into a sagittal plane, into a coronal plane. This is the third step, step number 3 in the dance. So step number 1, step number 2. Why the suction is not sucking?
It's not nice.
Okay, step number 3 is conversion. Step number 4, everything changed to 0 degree debrider. See here. Now what I'm going to do is, you see here, you have to.
Debrider ready.
Now it's all about the debrider. See here. See the movement here. This movement is like this side to side movement. Maybe here. See, this is the commonest site for recurrence. If you leave behind this one, it will recur. So that's called the uncinate lamina. That is according to David Kennedy. That is the commonest site of origin of the polyp as well. First site of origin. Now that's a bulla. You can see the bulla, it's a little bleeding. Maybe because it's not been prepared.
Okay.
Don't worry, keep irrigating, keep irrigating. Now you see that's a bulla. Just penetrate the bulla. And move like a beggar's movement. I call this a debrider block.
Suction.
Now again, don't suck the middle meatus. Suck the coena. Give me a pack. More debrider block. Take a pack and just fill the bulla. And then what you can do is just with the pack, you can dissect the bulla. So that's so easy to do. And till you get the debrider ready, you can actually clear all this. You can actually go towards the basal lamella. Debrider, please. So I almost dissected the bulla. Now you see here, this is bulla down technique. And you can see here, see the movements of the debrider. Very, very important. Hey, block again.
Pack.
Pack. So whenever there's a block of the debrider, pack. This is your mantra. Don't waste your time by suction. Don't waste for the debrider to get cleaned by your staff nurse. It is blocking because the suction is not very powerful. Ready? Now you see here, just 5 minutes since I've started this site, and now I'm taking the debrider again, and see here, see this. This is called the bulbar lamella. So see how gently I'm using that, like a paintbrush. It's like a paintbrush. So I'm defining the lamina papyracea. Okay, you all understand? See the lamina papyracea. This is the ethmomaxillary crest. That is the basal lamella. I'm already penetrating the basal lamella. Keep irrigating, my dear friend. This is the posterior ethmoid. When you go to the posterior ethmoid, your debrider is directed away from the optic nerve. Always remember that the skull base tapers downwards. Never go in a straight line.
Very important reminder, sir.
Now you can see how beautifully that's the lamella of the basal lamella. Now you see I'm doing what is called the Jula technique. See here, you move from the lamina, that's a middle turbinate, towards the middle turbinate. See that? See this movement. They're very, very important. And then you do what is called the baby walk. Block. If it's block, give me a pack. That's very important. Have a pack. Now it's around 8 minutes since I've started the surgery. Suction, please.
Ready?
Always suck the coena. And then, yeah, this again, this technique I told you has been published. I'm not bothered about the skull base at all. I just want to open up the sphenoid sinus. That's it. I'm not going towards the skull base because the best landmark for the skull base is the sphenoid sinus. The planum is the best landmark. So here we are. Keep irrigating, my dear friend. So I'm doing what is called the Jula technique. Can you see the superior turbinate here, all of you?
Yes.
Yes or no?
Yes, sir.
That's the superior turbinate. See how I've changed my direction of the debrider away. Go inside and irrigate. From the septum. See, now I entered into the sphenoid sinus. That's the sphenoid sinus which has been entered already. That's the Parsons ridge. Irrigate. Now it's a little bleeding. Don't worry about that. Don't use the debrider inside the sphenoid sinus. Only the anterior lateral wall should be done with the sphenoid sinus. Now the moment you enter into the sphenoid sinus, you should always try to define the planum. Can you see the planum there? Suction.
Ready?
So what I'm trying to do is to define the skull base at the level of the planum. Now it's around 8.5 minutes. I'm not trying to time my surgery, but I want to tell you that it doesn't take much time if you do it the right way. Even if there is a grade 2, grade 3 bleeding, it's not a difficult surgery. Now, I'm just going to take off this and then I'm going to define the planum. See here. Once I define the planum, that's the planum here, that's the planum. See, that's the planum. And you see the movement of my debrider now. See the movement of my debrider. This way. 1, 2, 3, 4, 5, 6, 7, 8, 8, 7, 6, 5, 4, 3. Next and change. That's beautiful. I have now defined the skull base. Now what you do is once you enter here, that's a middle turbinate here. And here is where the anterior artery is supposed to be dehiscent, right? Now it's very simple now. The frontal, everybody is scared of the frontal, this, that, nothing bothers, nothing to be scared about frontal. I'll tell you how to do the frontal in the easiest possible way. Easiest possible way. So this is around 9 minutes and 20 seconds now. I finished the sphenoid sinus. I have just the frontal and the anterior artery to be delineated. That's it. So the next 3 minutes, I'm done. So there are two ways to do the frontal. The first way is sort of a very expert way of doing the frontal. The second way is the beginner's way. Which do you want to see, the beginner's way or the expert way?
Which one you want to see?
Which do you want to see? You want to see the beginner's way or the expert way?
Beginner's way.
Beginner's way, I will teach you the beginner's way. This is how I've been teaching my residents. Okay, give me the 70-degree telescope or give me a gauze, please. Half gauze. Half ribbon. Okay, this is the easiest way for a beginner. You take the 0-degree telescope. Not that, I want a little longer. Oh, okay, that's fine. Okay, you know that that is the frontal sinus, which is very, 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 very wide frontal recess. So what you do is you take this gauze piece and go behind. 1, 2, 3, and 4. See, that end is going like this. That's it. Now, give me the J curate. So this will never, ever produce a CSF leak. See here. Now you are hugging the axilla. Can you see the axilla here?
Yes.
Yes or no?
Yes, yes.
So there is the interfrontal cell which is draining into the left frontal sinus. That means the frontal drainage pathway is lateral. Now you just have to go. You can go blindly, but you should never, never go with your forceps. It should be only with your gauze piece. It should only be with your, my dear friends, only gauze piece and very, very, very mild pressure. That's it. Now give me the 70-degree telescope.
70 ready.
If you have a wide frontal recess,
Debrader ready. After.
your pressure, the pressure is very important. And if you're hugging the nasofrontal beak, you will never ever go into the
Upturn.
So that's a 70-degree telescope. Upturn.
Ready.
So don't bother about this cell, that cell, good cell, that cell, everything. See here, I'm just going to take this out. Rat 60 debrader blade, please. See here. Now I'm already inside the frontal. I don't know if you can see that.
Yes.
It's very, very, very. See here. Now I'm just following the nasofrontal beak here. Just follow the nasofrontal beak. So what I'm doing is I'm using the debrader as a elevator. Use a debrider as an elevator. You understand? So that is the most important thing. You will never injure the anterethmoidal artery if you use the debrider as an elevator. This is very, 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 unless it is almost in the middle. So here we are. I'm almost done with the frontal. I'm just going to show you the anterethmoidal artery. Boss, FESS is so simple. People complicate it. That's it. And they are scared of the frontal for no reason. And they are afraid of the anterethmoidal artery, which is just nothing.
It's not no reason, Janakiraman.
Huh?
Not no reason, Janakiraman. They are afraid because they are not confident of the complications.
Can you see that anterethmoidal artery here, my dear friends? See here. See here. Yes or no?
Yes.
So that's a phobia. This is a phobia. That's anterethmoidal artery here. That's it. Finished, boss. What is there in FESS, boss? Debrider. Now I have to connect the frontal sinus with the anterior fovea. As simple as that. As simple as that. Now that's anterethmoidal artery. Now what I'm going to do now is to pack, and I'm going to show you what are the boundaries of the frontal recess. Give me a suction. Give me a good wash, please. Wait, I'll just take the gauze piece out. Now I'm sucking. Give me a good irrigation. Okay. Okay, now I'm going to show you frontal sinus suction tip. Yeah, I'm going to show you the boundaries of the frontal recess. See here. Okay, straight black slip, please. Quickie. Okay, here we are. I'm going to take this gauze piece out and I'm through. Okay, what are the boundaries of the frontal recess now? The anterior boundary is the nasofrontal beak. Can you all see the nasofrontal beak? Yes or no?
Yes.
Anto?
Yes.
Left off, as usual. The lateral boundary is the lamina paprasia. That's the lamina paprasia.
Okay.
The medial boundary is the middle turbinate. The posterior boundary is the anterethmoidal artery, which is here.
Okay.
See that? See how beautiful. That's anterethmoidal artery, anterior fovea, frontal recess. This is the lamina paprasia, middle turbinate, nasofrontal beak. So that's it. What is there, boss, in this? Finished. Now give me I'm going to check the maxillary sinus now. Just to check if there are any polyps, type 3 polyps there. Not really. So this can be managed without any other approach. Okay, give me the 0 now. I'm fine. So that's the end. I told you around 15 minutes it takes the whole surgery along with a complete full house FESS. Straight, please. Takes around 15 minutes. Now, straight suction, straight debrider. Now, what I will do is slightly modify this cavity to a very smooth looking cavity. You can see here, that is the choana. That's the middle turbinate. Very nice, stable middle turbinate. And then that's a sphenoid sinus. You have a direct look of the sphenoid sinus. There's a little polyp there, which I'm going to take. And there is a little, give me a down biting sphenoid punch. Down biting sphenoid punch, please. I need to widen the sphenoid sinus nicely. Only here. Okay, I just want to catch it up. I'm not going to, pull it. Just trying to destabilize. Then I'll use my debrider now. Now I'll use my debrider. Widen that sphenoid os so that when I see from here, give me the Blexley. Can you see the sphenoid os, all of you?
Yes, 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 very well.
So from here, if you look, you should have a look of the frontal above, the maxilla here, and the sphenoid here. That's a post-operative view. Give me a debrider again. Debrider. Now I don't want this a little bit here. So a little bit of trimming here is required. There could be a Harzella cell here. That's it. The lamina papyracea looks beautiful and smooth. No stalactites. Anterior ethmoidal artery is here. Right here, the anterior ethmoidal artery. Give me a pack.
Ready?
I'm just going to have a white pack to show you how the cavity looks. I have to have a look at all the three sinuses with a 0-degree telescope. Only then your FESS is complete, my dear friends. One more pack. One more pack, please. Quick, big pack though. Bada pack though. Shilpi Bhatia. Now that is in the sphenoid sinus. Now, pack डालने के लिए Blexley दो, ठीक है. Now be very careful when you're packing. Don't destabilize the middle turbinate. Okay, here we are. Okay. See how I'm packing without even touching trauma, no trauma. No destabilization of the middle turbinate. Now have a look, my dear friends. See this cavity. Looks so smooth. Frontal sinus suction tip. Frontal sinus suction tip. Now I'm going to show you the cavity, my dear friends. This is the final look. The maxilla is seen here. Beautiful. The choana is seen here. Middle turbinate is stable. Sphenoid sinus, lamina papyracea, skull base, anterior ethmoidal artery with a 0-degree telescope. See that? It's dehiscent. Can you see that? It's dehiscent. My dear friends.
Yes.
That's frontal recess and that's the frontal sinus. You can see the frontal sinus with the 0-degree telescope. Frontal sinus, anterior fovea, anterior ethmoidal artery, posterior fovea, planum, lamina papyracea, maxillary sinus, choana, middle turbinate, nasofrontal beak, and this is the olfactory cleft. Thank you very much, my dear friends. Thank you very much. Thanks a lot for being with me from Goa. I hope you'll have a good second day. The second side, of course, Shilpi will be doing and they'll not demonstrate. Thank you very much. So you have any questions?
Questions?
So that was just a rapid fire. Within 15 to 16 minutes, complete FESS, full house FESS. Yeah. So thank you very much and have a very great day. Bye-bye.
Thank you, sir.
Thank you very much, sir, Honorable Janakiraman, sir, and entire team for your fabulous.
Thank you so much,
Nice
Sun
experience
Pharma.
given by to all the dignitaries. Once again, on the behalf of Sun Pharma team, Pharmacare team, sir, thank you very much, respected doctor, sir, for giving your valuable experience to all the dignitaries, all the audience. It is going to be helpful to across the country. So once again, a hearty vote of thanks to all of you on the behalf of Sun Pharma, Pharmacare, and respected Janakiraman sir and respected Honorable Dr. Murthy sir for moderating the session and enlighten all the and Dr. Anthony sir for enlightening all the dignitaries and enlightening the enlightenment of all the group. And it's going to be beneficial for across the country to the entire patient. So thank you very much, sir, and have a wonderful evening, sir.
Thank you and wish you the same. Enjoy yourself. Enjoy Goa and good academics. Thank you.
Thank you, doctor. Thank you.
Thank you.
Thank you.
Anthony, special thanks.
Next time we will meet here live, sir, so that you all also can enjoy with us.
Then you have to get cases in Goa, my dear friend.
Sure, sir. You must be having contacts in Goa also.
Yeah, of course, of course. My friends are there. Yeah, that's right. Thank you. Good night. Bye-bye.
Honor and
Good night.
pleasure.
Good night.
Actually, Sun Pharma arranged for a good dinner here. And thank you, Hyderabad Sun Pharma also. Special thanks. The dinner was very good. Thank you very much.
So it's our
That's why-
pleasure, sir.
That's why I could complete it in 16, 17 minutes because the dinner was very good. Thank you.
It's a pleasure, sir. So you're giving a valuable time to us.
Yeah. Thank you. Thank you.
Thank you, sir. God bless you and all the team members who are supporting you in such good work, and you are doing such a humanitarian work even through your thousands of camps, and even all the doctors here who are working for patient benefit. Thank you, all of you from Sun Pharma team, and you all means a lot to us. Thank you. Good night.
Bye-bye. Good night.
Good night, sir. Thank you.
Sir,